Good afternoon. I think it's a very good initiative to have a master class like this on a focus topic, which is quite problematic for all of us. These patients come. Now, since mine is the first talk, I'll just go through few basics also, because there'll be a mixed audience. So this is essentially what is skull base osteomyelitis. It is a process starting from the necrotizing otitis externa, and it's a progressive infection involving the skull base. Essentially, there are two types. The one ENT more commonly sees is the lateral type, or it is a typical skull base osteomyelitis. The other one is central, which more often presents to the neurologist because there are very less ear findings or no ear findings. There may be nasal symptoms, and it is very important to differentiate between the two. Now, here the origin is in the temporal bone. Here it's the sinuses, sphenoid, occipital condyle, central skull base. In the lateral type, the commonest and probably in 90% cases, you will grow this organism is Pseudomonas aeruginosa. While in the central type, it can be fungal, Aspergillus, Candida, it can be bacterial. In commonest, there is Staph aureus. Now, always there is an underlying condition, mostly always, in skull base osteomyelitis. In the lateral type, diabetes, most common, uncontrolled diabetes in elderly patients, or who are immunocompromised for some other reason. While in the atypical one, immunosuppression, especially in post-transplants, HIV, patients on chemotherapy, and even post-radiation necrosis. We see a fairly good number of patients post-radiation who present with a central type of skull base osteomyelitis. The lateral one presents with painful otorrhea. I think all of us who must sensitize our juniors, our residents, our colleagues to this. If your discharge is with a uncontrolled diabetes, have a high index of suffering. If you see, you will see discharge, you may see swollen canal, granulations, and sometimes in a later presentation, facial nerve paralysis. While in a central type, you will have headache. Headache may be one of the first presenting symptoms, which may be retroorbital or even occipital headache. They start with multiple cranial nerve palsies. And neurologists keep on trying to diagnose. Problem is there is no tissue for diagnosis, and most of their treatment is also empirical. So here, why it is more very good to have a interdisciplinary access and referral. So I have suggested several times to my neurology colleague. There is Dr. Vinay Goyal, he was his names. So sometimes once we discuss a case, he also agrees that this is likely to be skull base osteomyelitis. And the lateral one starts slowly as otitis externa and then progresses slowly to skull base, nerve paralysis, seventh nerve, other lower cranial nerve paralysis. While the central one is more aggressive, rapidly progressive. At times, you have to rule out a neoplasm malignancy. So now the nomenclature, different nomenclature. The correct scientific one is skull base osteomyelitis, but it is also called temporal bone osteomyelitis, a diabetic ear, malignant otitis externa. Avoid using this word because sometimes other clinicians get confused. The word malignant should not be there. I think they must do something to take it out of the literature also, though it is very commonly used. Necrotizing otitis externa, fine, and finally skull base osteomyelitis. So what happens? It starts as external auditory canal infection through fissures of central knee and osteocartilaginous junction. It goes on to cause temporal bone osteomyelitis. Then skull base extension, petrous apex, flyvers, occipital bone. Then there is perineural vascular spread, and in a evolving skull base osteomyelitis, it is not just the spread through these fissures. It goes on to a vascular or a perineural spread. Then once the nerves are involved, and then there are intracranial complications. These are all risk factors, and you must look for these risk factors if he is not in the care of an endocrinologist, nephrologist, or any other allied specialty, he must immediately be put in care because there may be undiagnosed condition. This has happened. He just come to us with pain, and when we saw even starting from uncontrolled diabetes to a chronic renal failure. Microbiology is important. As I said, Pseudomonas commonest, but others also grown. I'll show you a series of 4 cases. Currently, they are in our follow-up in Vedanta only. And one of them has Klebsiella grown. Then MRSA, Aspergillus, Candida, polymicrobial disease, any other fungus. Now, what are the predisposing factors? Diabetes, 90% cases, poorly controlled. So, marker is not your daily sugars, it is HbA1c. Anything more than 7, more than 6.4 is diabetes, 6 to 6.4 is pre-diabetic, but anything more than 7 starts the alarm. Then immunosuppression, chemotherapy patients, post-transplant, HIV, patient on prolonged steroids. This had happened during COVID also, the second wave of COVID. The mucormycosis patients, there was several of them had bad skull base osteomyelitis. And we saw these cases, they were derided, then they carried on over 3 years, 4 years. You do a CT, you'll see on clinical examination, yellowish bone, there was no active disease. This was just bone which was dead. And then chronic otitis externa, patients who start, diabetic patients who start on scratching their ear, it starts as otitis externa, and before you know, it has become skull base osteomyelitis. Even this happens with sinusitis also. Then post-radiation, chronic renal failure. Elderly patients, more than 60. Then this disease also, osteopetrosis, Paget's disease. Here also it can happen. So as I said, persisting discharge with pain, granulations in the canal, lower cranial palsies. Then lab workup mein ESR is raised. CRP and ESR, though they are better markers for follow-up. We must take a ear swab. If there are granulations, they can be sent for tissue culture, but that is more to rule out a malignancy. Then HB1AC. Gold standard is tissue diagnosis. Now the role of imaging. CT is important to see the bone destruction. MRI for soft tissues, for nerves, for intracranial spread. FDG PET CT for active infection, more for monitoring the response to treatment. Where PET is not possible frequently, technetium scans, gallium scans. And though they have low specificity, but useful, much cheaper than a PET. Now, management, the mainstay is antimicrobial therapy, and it should be culture directed IV antibiotics. Minimum of 6 to 12 weeks. We have patients who have gone on these for more than a year already. Several of them on follow-up. Local care is very important. Oral cleaning, but don't damage the canal. It's a swollen canal if you use a suction tip. Plus minus topical microbials, antimicrobials. Very good drop is 2% acetic acid. Wherever we don't get anything on culture, just installing vinegar, 2% acetic acid is vinegar, the chemical form, you install, they are helpful. Glucose, the sugar optimization, immunosuppression management by concerned specialties, monitoring by serial ESR, CRP, frequent MRIs. There is a limited role of surgery, we'll come to that, but for biopsy, yes. If there is a frank abscess, yes. Debridement, very select cases, except when there is pain is persistent, then you can do that. Or there is you need tissue from the mastoid, there is nothing in the canal, and still you are not sure. Now, remember, this is a mortality of 10 to 20%, increasing incidence due to diabetes, rising antimicrobial resistance. Our patients, which were very, very sensitive, maybe a couple of years to even Tazac or your meropenem, today, many of them don't respond. If you see the pus culture, they'll be all resistant. Only thing which will come sensitive is cholesterol. And cholesterol needs a hospitalization. Cholesterol, you have to really, it can be given, but in a controlled setting. Then delay diagnosis. This is very important. Sometimes they run through OPDs. Some of our colleagues are not sensitized to diagnosing still this condition. Not just the general physician, even ENT. The commonest mistake is in periphery misdiagnosing this to be unsafe CS1 and doing a mastoid. Now this is a big pitfall. If you do that, the patient will remember you all his life. And here, a high index of suspicion. This setting, discharge, pain, stop. Because CT will just show bone involvement. So ask for an MRI. MRI will show a good radiologist will pick it. But don't rush into surgery, because once you've done a surgery, his pain will persist, it will increase, his discharge will never go back, and it's a difficult patient for your follow-up and a stamp which will follow you. Now I'll show you 4 patients. These are currently undergoing treatment with us. We picked them up. Now this is a post-renal transplant patient. Then from he underwent renal transplant in Gangaram Hospital, was under care of Dr. Rana, and he presented with severe ear pain, discharge, and facial paralysis. There was granulation tissue, pus culture, no growth, ESR elevated, CT showed bony canal erosion. So empirically was started. Now see, she's received so many antibiotics. Initially meropenem, pus culture was sensitive, then piperacillin, tazobactam, then second pus culture, they both became resistant. Then the only thing which was positive was this fosfomycin. So he's been on fosfomycin now. Empirically started on voriconazole, because the nephrologist told the patient that can be fungus. So we said, okay, we will agree to that. He's be given voriconazole also. Oral toileting, glycemic optimization, MRI serial follow-up was being done. Initially, he did well. Then, last 2 weeks back, he started having headache. And we did an MRI again. He had pachymeningitis with, again, lower cranial nerve involvements. Lumbar puncture was done for CSF analysis to see if they could grow something, but nothing. And right now, he's shuffling between us and the neurologist. Now, this is a better treatment results. Uncontrolled diabetes, HbA1c was 16. Patient never knew he was diabetic. It was only done in the hospital. Otalgia, patoria, cranial nerves intact, and even just piperacillin tazobactam for 4 weeks, the Proflox drops, acetic acid drops, he improved. And right now, he's on follow-up. We are keeping our fingers crossed that he stays all right. The next 2 patients are also like this. The second patient, you can see the MRI and how the soft tissues are involved. The reading of MRI by the clinician is also very important. You must learn to, because you will pick up the soft tissue things, which average, you have to learn, try to read the MRI yourself, the report what has been given. And sometimes you will get extra findings. And here also he responded well. Even the EAC is tried, and he responded to ceftazidime. So this is another useful antibiotics. You must have 3-4 of them in your armamentarium and use as driven by the culture sensitivity report. And the last one, again, uncontrolled diabetes, Pseudomonas, IV ciprofloxacin. He started with this and then escalated to meropenem. Under follow-up, resolved. So 4 out of 4 patients, 3 are under control. I will not say they are cured. They can come back anytime. But 1 has deteriorated. So this is just a pilot to show what happens in these cases. And this is a comparison of all these cases, the underlying condition, of what organism. Now, most important thing is, once a patient like this comes to you, you have to handle them in a very mature fashion. The patient counseling is very important. Don't rush in admitting. Problem is, most of us are in corporate hospitals. The diagnosis you would have made clinically, MRI, CT, even if required PET scan, culture, all can be done on OPD basis. You can have them have their IV antibiotics at home, or even in emergency. Our emergency gives, they come daily. Because in hospitals, the bills sometimes get very high, and if they land up with a neurologist, some of them land up in ICUs. And the patient who's going to have treatment for 6 months, 9 months, 1 year, he gets his funds get. So we have worked out, we only admit if for immense pressure, sometimes they are sent from periphery or they have traveled a long distance, 2 days. 2 days, we diagnose, settle, and then put them on 2 weeks of antibiotics. Outstation patients, they do a video calling, ESR, CRP, MRI can be done, and we monitor them. Admit too long, there is a problem. The second is expectations and prognosis. Don't give them high hope. In the first setting, tell them about the disease. This is a disease where prolonged treatment is required. Prognosis is guarded. 50% will improve, 50% will not improve. If you give them very high expectation, then it is not. You have to be very, very honest with them in the first. This is a very important part of counseling. Slowly, if you deliver good results, it is taken better. Now, few issues in diagnosis. Best diagnosis. So many a times there is a reference almost 7 months. Patients are just being treated as otitis externa because patient comes with discharge, somebody puts a otoscope, it's a swollen canal, but beyond that, they have not applied. Sometimes diabetes has not been diagnosed. So at least where you see otitis externa, get HbA1c, smallest suspicion, get an MRI. The condition will be. Second is, this is what I said, mimics otitis externa. Then mastoidectomy done, several periphery patients. In a year, we get about 4 to 5 patients where mastoidectomies have been done. And the patient lands up, is done, pain persisting. It takes a very long time for them to get on track. So teaching institutions, wherever these are, this message must go on to our colleagues. Then central variety may not have any ear symptoms. This is the other thing. So have always a good dialogue with the neurologist. The central variety, there may not be any AT, it may just be a headache. But ask for an MRI temporal bone. MRI brain cannot diagnose. You have to have an MRI temporal bone. And then you may be able to diagnose. Then getting tissue for biopsy. In the canal, if there is something, yes, it is helpful. If not, you can do a cortical mastectomy, especially if the thing is dragged on for and you have disease in the mastoid. Most of the time it is in the lateral variety. You do a cortical and explain to the patient, I'm just doing this for a biopsy. Don't expect a cure. Now, the other problem is sterile culture. They have been on multiple courses of antibiotics, so cultures are sterile. So what do? So we have nothing else to do but shift from meropenem to piperacillin, tazectam, or fosfomycin or ceftazidime to do 3 weeks. And even if the culture is sterile, sometimes they work. They do. Now, differential diagnosis, some conditions, otitis externa, there is a condition called chronic otitis externa. Scratching, putting buds, keeps on happening. But here, to treat that, have a high index of suspicion. Then malignancy, sometimes metastatic carcinoma, initial if pain with discharge, carcinoma external aortic canal, have them at the back of your mind. Then fungal infection of skull base, very common, aspergillus, mucormycosis. If you don't get a tissue, I don't think it's a crime to put them on. If you are suspecting this sort of a thing, voriconazole, or if it is on the mucous side, more acute presentation, fosconazole. Empirically, you can start them, they are fairly safe drugs. Then petroseptic cholesteatoma, again, is a DD which is possible, and primary or metastatic skull base tumor. Then this spectrum of disease is also important. Sometimes in India, we do see TB. We have seen several cases. Then GPA, sarcoidosis, then this IgG4 related disease. Now, the increased awareness, more and more patients. We had a departmental seminar 2 months back on this IgG, and Mahesh, he's from AIMS. We asked him to present, and we were also surprised how more common it has become. It was initially some years back, you will not even think of this, but it is more common than it is actually diagnosed. So all these have to be in the differential diagnosis. Now, antibiotics, don't shy of prolonged antibiotic use. In between, what I do is, if I give her 4 weeks of IV, and patient is responding, I'll put him onto oral ciproflox or levoflox, depending on the sensitivities there. Obviously, you will not do for a resistant one. It gives him some break. but there is no, it has to be prolonged. Antibiotics, culture should be done repeatedly, but it may come sterile many a times. Now, patient can land up with cranial neuropathies. Later on, where once it goes intracranial, you may have cavernous sinus thrombosis, meningitis, brain abscess, ICA involvement. All this can happen. Now, which cranial nerves? Most common facial, sixth nerve in the petrous apex, ninth, 10th, very common. Then the swallowing problems come, the dysphagia starts, 12th nerve, the tongue movements are affected, and high rate of cranial nerve paralysis, especially in advanced disease. The thing is, even control the primary infection in lateral variety, the cranial nerve paralysis will persist. It is very, very rarely, though I will not say not always, you have seen them revert back once a palsy is occurred. So this must be explained to the patient. The vestibulocochlear nerve can also be affected. I'll show you one patient. This patient had come to us in 2011. He was a Jat Sikh from Punjab. He came with skull base osteomyelitis. He responded sometime, went on for 6 months, was given antifungals. Suddenly his hearing went off, and the CT showed involvement of the cochlea, the rest of the petrous temporal bone, and we waited. We told him there is the option of a cochlear implant, but we waited for 2-3 months till we were sure the infection is subsided. And then with the informed consent, we did an implant in him. He started hearing. And till about 7-8 years, he was a regular, he was on regular follow-up and did really well. So hearing, the vestibulocochlear nerve can be affected in the later stage. Now, the other pitfall is, please manage the comorbidities. Don't take the patient just to yourself. Diabetes, hand him over to a good endocrinologist, because if his diabetes is not controlled, these microvascular changes will hinder healing and they'll be more and more resistant. With every course of antibiotic you give, that will not work. Secondly, the post-transplant patients, again, be in tandem with your nephrologist. The commonest mistake is there are a lot of transplant patients who can't be given drugs we are prescribed. Like they will have objection to your meropenem. They will agree for Tazac in a lower dose, but they will say raise the thing above meropenem. So always consult with them. Second is, few of the more aggressive ones, they start blaming. Why did you give? My transplant went. So I always write, if okay, by nephrologist. If it's a CKD patient, I prescribe something, I ask him, get a WhatsApp okay from the nephrologist. Then interdepartmental coordination. Role of surgery. Surgery is not the first line of treatment, though there is a group of surgeons who have their expertise in skull-based surgery and they like to do these. But again, I will not agree with that. It is a extensive spread out infection. So I don't think we had Dr. Mahadevaya and my friend Dr. His disciple in Bangalore. Dr. Mahadevaya was very fond. We had invited him for a workshop in 2010-11 and he operated. The surgery was very nice, but we had the patient follow. They do it. Upfront surgery, we will not go for extensive debridement. Yes, 6 months, 9 months, your antibiotics have not worked, then you can give him as a second line choice. This is the chance of my curing your disease. Then yes, otherwise no. If you see abscess, that is the brain, diagnostic biopsy, yes. If there is severe pain, and especially localized to the mastoid area, you can debride. Nerve paralysis, again, it is not a first line indication for surgery. I don't think we can have a debate later on, a discussion, whether decompressing facial nerve in skull base osteomyelitis will help at all. Should we do it or not? We'll leave it for later discussion. So thank you. This is a gist of things with skull base osteomyelitis. And before we come to the question, just one more information. We are having annual conference of Association of Neurosurgeons. The venue is Dwarka, your Taj Vivanta Dwarka, February 5th, 6th, and 7th. So you're all welcome to. Any questions? Happy to answer.
This one thing is looking back.
Yes, after 10 years, 2017 was the last. This year, yes, yes.
So, sir, actually, very well summarized. It actually beautifully sums up the entire topic. And I think most of the points out are very crystal clear. And we subscribe to all of these things that what you just said. Sometimes, however, in imaging, whether it is a contrast CT or MRI, there can be ambiguity about what is necrosis, what is an abscess, what may not be an abscess. And as you rightly said, in case of a progressive symptoms and pain not relieving, and if you can get away by a limited procedure, then of course that could be a part of the thought process. So first line management is antibiotics or antifungals, depending on what the cultures grow. So I think if I may ask just one most important thing that you would like to say to everybody in terms of their suspicion for this disease, so that we are more prudent about our use of antibiotics, obtaining our cultures right in time before they become practically nothing.
So I will repeat, have a high index of suspicion. This is common. Don't miss the diagnosis. Slightest suspicion, treat your otitis externa, but also obtain a pus for culture sensitivity. Get preferably a MRI unless cost hinders. Even CT will be helpful, but MRI for soft tissue is more helpful. And patients do better if treatment is initiated early. And treatment does not just mean the ear treatment, it means the control of diabetes also. Because if that is not controlled, how much antibiotics you pump in, you will not get better.
Right. So I have two questions. One is, what is the indication of cortical mastectomy for biopsy purpose? So when will you do a cortical mastectomy for biopsy only?
So clinically, if we suspect skull base osteomyelitis, we will start antibiotics. If there is granulation in the explanatory canal, we will take that for biopsy. Say you have given antibiotics for 3 months, still diagnosis is not sure. At the back of the mind, sometimes it can be a malignancy. If there are your granulations have not yielded anything, there is soft tissue persisting in the mastoid, then you can just do a control hole and take a tissue form. Explaining to the patient, this is not a treatment, it's just a charge. Because we have seen malignancy also missed. Patient treated for 2 months, 3 months, and no biopsy. At least medically you are safe, you take a biopsy.
I have a comment on that. In fact, I've found that misdiagnosis is more along the lines of malignancies being missed than the so-called malignant otitis externa. Most people are able to diagnose malignant otitis externa or skull base osteomyelitis, but I have had a lot of cases where it's the malignancy. And like you said, giving antibiotics for 2-3 months and then diagnosing, it's that you are
not that diagnosis. Means if it is not resolved.
I understand that I am talking about for the purpose of the general
malignancy. If it is a malignancy, in 3 months it would spread to lot more areas, right? So it will be a very clear-cut diagnosis. Even on CT, you will find that there is extensive destruction.
Not necessarily. Right? I have actually encountered, and I have images to prove it, where diagnoses have been missed for this reason, that it was not as aggressive as it was. So my protocol is
few slides on CT versus MR comparison.
Yeah.
And I am
second
put
thing,
that for the very important.
because my
second question was like,
sorry.
When you said that patient had vestibular cochlear nerve involvement, then why a cochlear implant was done? Because if the nerve is involved, then
No, nerve is involved,
but then it should not be improving.
no, he was started here.
Improved.
All this was discussed with him. We told him it's an infection. There, your nerve is involved. It's the nerve of hearing, and there is a good chance that the implant may not work. We gave him a 30-40% chance.
Agreed. But sir, if the nerve improves, then there is no need for a cochlear implant.
The nerve is not improved. The nerve is able to conduct electrical sound. The nerve is not improved. It is not a functional improvement. The
ganglions are intact, but
the functional improvement of the nerve is there to conduct the electrical signal, and then only the cochlear implant will work. If there is no functional improvement, the cochlear implant will not work.
If you had not done the implant, which was not done for so long, there is no improvement in hearing. We can discuss the mechanism, but once you did an implant, the electrical impulses were getting
There are two things. One is the anatomical continuity of the nerve. Second is the physiological function of the nerve. So if the nerve is involved with the disease and it is not functioning physiologically, then there is no point in doing cochlear implant. That is the logic.
This is these are real-time situations. So even we were very guarded in doing this, but this actually happened. And it is
That means the nerve improved.
no, but then you should have started hearing if the nerve he is not between the day of surgery and
The whole discussion of when to implant, even in a hypoplastic nerve or a poorly functioning nerve, is I think
So Kapil, let's take a comment from
of today's discussion.
let's take a comment from Dr. Kapil on this.
That is a separate discussion.
So
Yeah.
pure nerve involvement I have never seen happening in skull base osteomyelitis.
Yes.
It would have
Eighth nerve is
been
relatively
either
spared.
toxicity.
In fact, if
nerve
you've
damage.
got an eighth nerve involvement, first think in terms of herpes osteocephalitis rather than think in terms
That
of.
is-
So that is a far more common.
So this is the same of Skull Base Osteomyelitis.
I have
So it is possible there is another reason.
Vitreous bone involvement can happen, but as sir is mentioning, it's not purely auditory nerve. It is
Yes.
cochlea plus vestibular and cochleovestibular nerve. So it is cochlea plus cochleovestibular nerve that is involved. And I'm sure that since they were able to insert the implant, anatomically cochlea was normal and intact, and it was induced labyrinthitis that led to hearing loss.
Correct.
Could be
So
that.
that is a
Yes.
more
Yes.
plausible explanation
Yes.
that the cochlea itself was involved, not the nerve was involved.
Correct. So in the interest of time, I think we proceed to the
Sir,
next.
आजकल actually anatomically intact nerve में even acoustic neuroma excisions के बाद
But
they
they
are
take a-
trying
Yeah.
implants
Yeah.
rather than
As long as
only
the
saying
nerve is
that
intact,
nothing.
yes.
And for auditory neuropathy, where you know that nerve is dysfunctional, still cochlear implant is the first option because they say that others are inferior. So results may not be as good, but
Hey, auditory neuropathy results are good.
yes,
Not all cases.
maybe not as a novel retrocochlear. They are sometimes very dicey. So some of them may respond, some
Yeah,
of them.
it's a variable response that you get.
Right.
Kapil Sikka sir requires no introduction. Sir is from AIIMS Delhi. He is an authority on this topic itself, so no better person to speak about it. And sir will also talk about the experience. He had multiple pieces, I believe, also on this subject. Sindhura was just here some time back. She had her thesis on this subject as well. So I think let's start with sir. And as the session progresses, we'll keep on discussing some nuances, save some for the panel discussion as well. So we'll get to again rediscuss some of the pertinent panel discussion of the 25%.
2 minutes. So
They want a Zoom link.
I could say that.
yahoo.com ना सर
हाँ बिल्कुल
kapil.sikka@yahoo.com
Kapil_Sikka. Kidnapped rather.
नहीं हमारे सारे प्रश्न बीच में घूमते रहते हैं होता बेटा बीच में
Because she tried, she honestly
Our
tried our hospital. दो बार तो कोशिश करी, then she gave up.
सब अपना अपना काम कर रहे थे एंटीबायोटिक्स में तो हम बताइए मैडम है
Please a disconnection. He wants me to connect to Zoom. So I take 2 minutes.
ओके
कोई बात नहीं.
I don't know. But I'm better.
Life is
I'm better.
a collection of a lot of painful journeys put together.
Agreeing that getting to understand that now. हाँ बैठ बस यहाँ तक टाइम का तो आ गया टाइम काउंट्स
crash course on,
Yes.
on the subject, and I probably would have very few things to add to that. Some of the points that Ashish was mentioning about our research, I have put in a few slides on that. But I was attending the International Academy of Otolaryngology meeting a few years back, and there was a discussion on very experienced people, Dr. Mohan and others were sitting, about most frustrating diseases that they have treated in their ENT career. My talk was on papilloma, sir. I think there were a few of your cases and few of our cases. I was talking, and it was considered one of the very frustrating diseases that ENT surgeons treat. Another was laryngothracal stenosis, two in laryngology. And third one was this, that many surgeons quoted that it is one of the most frustrating diseases that they treat, both from physician's perspective as well as from patient's perspective also. So not easy to treat, no direct guidelines, but we have tried through our research and thesis that we have done in past few years to formulate some experience-based suggestions. I'll not say them as guidelines. So sir had mentioned that there are very many terminologies. So if we go back, this is probably early 60s or late 50s, if I'm not wrong. Chandler was one of the first who had described this treatment. And through my internet search, I could find his original article that was by James Chandler. They have said this is about infections of ear canal. They can be either circumscribed or they can be very diffuse. And he was one of the first to describe this as aggressive, potentially lethal bacterial infection that involves ear and the skull. So this is direct snapshot that has been taken from original article that was written by James Chandler from Miami, Florida. And in this report, this was actually a case report. It describes the etiology, pathogenesis, diagnosis, and treatment of this serious infection. And he has coined the phrase malignant otitis externa. He was one of the first to describe this as the disease entity. So our experience dates back to maybe last half a decade. And I sincerely acknowledge all the contributors here. It's myself, Anup, I'm lucky he's here. We work in same unit. Dr. Sindhu, I'm lucky she's here. Dr. Aiza and Dr. Alok Thakkar. We have formulated our experience based on prospectively kept data. It was a prospectively kept data. Initially, some subjects were retrospective of around 63 subjects. So I'll be trying to break some myths regarding this, which are prevalent in general population amongst the ID group and also amongst the ENT specialists and surgeons. Our median age, if we looked at these age 63 years, was 63 years of these around 60 plus patients, and range was from 18.5 to 82 years. But as a norm, as a disease, this is a disease of older age. Most people are in their 60s or 70s, and 90% because of vague unknown reasons. I tried to look at this, possibly some hormonal influence, possibly some vascular influences, but this is a disease of males. You will rarely see a skull base osteomyelitis patient being a female. Most common, sir had alluded to in his slide, most common symptom at presentation is pain. If you ask me one thing that needs to be done to have suspicion on this disease, it is that painful otorrhea should be the symptom that should alarm the clinician in this, followed by ear discharge. Pain was not, it was almost 100% of patients will have pain. Ear discharge is not 100%, it's not a certification of disease, but it is seen in around 68%. And facial or other cranial nerve involvement is also not rare. We saw it in around 40% of our cases. Patients have severe pain, and most of the times pain is nocturnal. They will be in their day-to-day activities during daytime. They will be busy in their works, but as soon as the evening sets in, they will see that pain doesn't let me sleep at night. Typical analgesic requirement will be higher during night time. It might have something to do with cortisol, or might have something to do with the diurnal with rhythm or something of that sort. 21 or 33% of our patients only, this might be a institutional referral bias, but we got only 1/3 of patients who didn't have cranial nerve involvement. Most of our patients had one or more cranial nerves involved when they presented to us. And as sir very rightly mentioned, this is a disease of immune compromised patients. Almost all of them, you will hardly have a patient who is otherwise healthy. You don't find anything. and you have skull base osteomyelitis. So 90% diabetics, 90% of them were diabetics. And it is probably a multiplicative effect to have a diabetes with neuropathy, with nephropathy, with a post-kidney transplant. So around 10% of them had multiple comorbidities, that is diabetes with CKD, and they were post-kidney transplant patients. Sir also mentioned about ESR, CRP. We were conventionally taught by our teachers that we should do ESR, we should do CRP, and we should follow these patients up with CRP and ESR. We tried to look at this, and Sindhu played a big role in this. Are they good markers to assess disease response? Should we do ESR and CRP, and should we not? Some very interesting points emerged. These are the median ESR values at 0, that is at presentation, 2 months after presentation, on regular treatment, 4 months and 6 months. What we found was that both drop over time. If you treat, patients improve, they will drop, but they will never reach baseline. If you look at ESRs of 10 or 15, they will probably never reach that, but they will definitely decline. And this decline is definitely proportional to treatment response. If the patient's pain is responding, he is getting good response to whatever treatment you have given, whether it's a medical treatment or surgical treatment, his ESR or CRP will decline. So it's a good marker to tell you that things are improving, but it will never reach baseline. You cannot attribute it to cure, that ESR came to baseline, now the patient is cured. But the patients who responded to treatment, they had got better ESR responses and CRP responses as compared to patients who did not respond to treatment, who were pain score 7. After 2 months also pain 7, they were higher ESR patients. In those who responded to treatments, the ESR and CRPs responded, but they didn't come to baseline. That was the thing that we could bring out through the research that we have done. Sir raised a very, very relevant topic, and it was being discussed on what is the ideal radiology. What should be done to diagnose this condition? Diagnosis clinical. You should have a degree of clinical suspicion with your experience that this is probably a skull base osteomyelitis. If you ask one investigation, cheap, best is probably the CT scan, single most useful investigation. But 99% of my patients, for our patients, they will end up getting both CT scan and MRI. In today's era, we should not be risking a misdiagnosis, and we do almost always both CT scan and MRI for a day 1 diagnosis, that is to diagnose this condition. And there are some characteristics which I will come on. Sir also very rightly mentioned about the cortical mastectomy. Surgical procedures will entail a biopsy so that you are not missing out something else. Most of them will end up getting biopsy. So ideally, if you look at literature and experiences, biopsy, this is a clinical and radiological diagnosis. It should not need a biopsy, but it should be done to exclude other diseases that are very important to be excluded. I found this image very interesting. It's by Tristram Dessers from Liverpool. He had published a series of radiological involvement of skull base osteomyelitis, although I could not find typical Lesser's presentation in my cases, but this is a good way of looking at things. If you look at the image on left side and look at the image of right side, they are just post-contrast images of same patient. Look at the way the disease is behaving. Clivus on this side looking whitish, clivus on this side looking blackish. This side, there are no landmarks. You can see the muscle and fibrofatty tissue enhancement on the uninvolved side. As soon as you give contrast, the normal anatomy starts to appear. That's how he has described a post-contrast MR image of skull base osteomyelitis. I will not say that this is a gold standard of assessing this, but this is how I try to look at the images, and some of them do correlate with what he has described. If you look at the patterns, someone was mentioning about the destruction on CT scan. That's not always the pattern. From our experience, we have evaluated there are 3 patterns on which these patients present. Look at number 1. This patient I'll discuss a bit of detail in later slides. This side has undergone a radical mastectomy and it's filled with something, either a muscle or some fat. Look at the other side. This is the area of jugular foramen. It's clearly medial to mastoid, possibly medial to the styloid process. And you can see there is some permeative destruction happening there. Other side, you will see this type of pattern where you will have a lot of sequestrated bone, probably seen in cases who have got a traumatic history, superadded with the immune compromised status. And in some cases, this is a CT image, better seen on MRI, you will have some micro abscesses. And one of the signs that we have recently found is the widening of temporomandibular joint. If this is found, it's a norm that you will find pus in this area. Some may say that this is probably a tilted CT, but I have seen it more than a coincidence that this side temporomandibular joint is probably expanded more as compared to the other side of joint. And you will find some disease in the infratemporal fossa and the TM joint area. So these are the three patterns by which the disease presents: the permeative destruction of bone, sometimes sequestrated bone, lot of sequestrae lying here and there. And third is the microabscesses, and they can extend medially along the infratemporal fossa right till the lateral wall of nasopharynx. This was from Dr. C.S. Bal. He had studied SPECT CT for evaluation of skull base osteomyelitis. If you have read older textbooks, they said that you should do bone scan, technetium bone scan. But they have said that 3D SPECT CT superimposed on whatever gamma imaging you are doing, maybe bone scan or technetium scan, it is better as compared to conventional two-dimensional bone scans, if I may say so. There was a debate whether the disease is bacterial or fungal. You cannot definitely say unless you take specimens. But this is ongoing study by Dr. Ashish. She is our radiologist. They have done a diffusion MRI and they have found that in initial few cases, which were diagnosed bacterial and diagnosed fungal, they have found that there is higher ADC, that's the diffusion coefficient in bacterial as compared to fungal disease. I presented similar slide in PGI a few months back. Some of them said that there is some data which is refuting this. But this is an incomplete study, and I have taken this slide from a radiology department with due acknowledgement of Dr. Ashish. So they are saying that ADC values can probably help you differentiate whether this is bacterial or whether this is a fungal osteomyelitis. But if you're not able to diagnose, in some cases, we do start empirical antifungals also, as Sir was mentioning, more in cases of central skull base osteomyelitis. That's the staging which Dr. Thakkar reported. There have been few changes to this because that was the era, probably it must have come 30, 35 years back. That was the era where radiology was not too accurate, but this is what we have followed for our studies. Simply speaking, stage 2 is disease that is lateral to jugular foramen. Maybe the cranial nerves, etc. are not very much involved, and disease that has crossed the jugular foramen, clinically manifesting as the cranial nerve involvement, is considered as stage 3. So there are few representative cases where disease has crossed the jugular foramen, causing some bulge and abscesses on other side of nasopharynx, and disease that is limited to one side of jugular foramen. Organisms, Sir had mentioned that most common is Pseudomonas. Totally agree to that, but commensals are not rare. Commensals is that you get the report that greater than 3 types of bacteria grown. It's not a rare report, and it was the commonest scenario in our setting also. We got it in 46, close to 50% of patients. We did not grow any bacteria. So taking swab from the ear, sending it and culturing it is not the method. So Sir was very much emphasizing on doing a cortical mastectomy, and sometimes we have got those cultures by doing a simple myringotomy and sending the middle ear fluid or middle ear mucosa also for cultures, because that is the more accurate way of doing it. If you send cultures like that, in close to 50% of them, you are not going to grow anything. It's not going to add to your clinical judgment. But if you grow something, Pseudomonas is the most common bacteria that is found in lateral or autogenic skull base osteomyelitis. And this is a norm. It's not that in India, we don't send the cultures properly. This is from OCNA. They have also said that usually it's commensals that, and most frequently they are coagulase negative cell. And that's not the bacteria to be targeted for its treatment. It's worldwide. It's US, in UK, everywhere. Most common organisms are the commensals. So I think we have an ID lecture also. I will like to hear that. One of the reasons that I am here is that we wish to hear what the infectious disease specialist mentioned. I don't agree with all of those recommendations. They have said one antibiotic if it's gonadotropin intolerance, but I've hardly seen a patient who's cured with only ciprofloxacin in skull base osteomyelitis. I will not agree to that, but I like to hear from what the ID says. But that's the rough chart that I could find in one of the papers. Central skull base osteomyelitis has emerged. It's not no more an emerging entity. This is one of the systematic reviews few years back, where classic signs of autogenic, that is discharge, ear pain, are missing. Patient typically presents with headache. He will present like this, nocturnal, one-sided headache with sometimes cranial nerve palsies. So more rhinogenic symptoms than autogenic symptoms. And differential diagnosis for youngsters, one of them is nasopharyngeal carcinoma. I am very, very finicky in taking biopsy from nasopharynx. In case you have not done, those who have worked with us, they know that nasopharynx has to be biopsied. Even if it's a blind biopsy, we have to rule out a nasopharynx carcinoma, because NPC, nasopharyngeal carcinoma, and sometimes adenoid cystic carcinoma, they are very, very close mimickers. They can mimic, and you can misdiagnose and mistreat them as skull base osteomyelitis for months, but don't miss this entity. High index of suspicion, any suspicious area, take a biopsy, rule it out. At least you should be clear that this, I did a biopsy and it was not there. And these are all others which sir has also put in his presentation. Once the patient presents to us, we start them on medical treatment. It's generally multi-drug. I will never start them on single drug. However, I'd like to get ID's opinion on that. Directed at Pseudomonas. If you don't have any cultures, direct it at Pseudomonas. Or if you get some cultures, direct it at that culture. Our preference is piperacillin tazobactam, which comes as a brand name Zosine, and sometimes Ciplox, nettlemycin, amikacin, or combination of 2 or 3 of these initially. The renal impairments precludes this treatment, and it's very difficult to titrate the dosages in patients who have got creatinine of 4 or 5, or they are post-renal transplant, especially amikacin and aminoglycoside. So you have to consult them, and very, very close consultation. We have seen patients treated with one of these. I think nettlemycin is also nephrotoxic, and they can be really challenging. Surgery role is selective. Sir had very nicely put in his talk on when to operate. But if you look at literature, there are 2 schools of thought. Look at left side. Present study highlights several important aspects with major implications for diagnosis. In contrast to restrictive attitude towards surgery, we recommend early and radical operative treatment to reduce its mortality. Contrast to what sir has said. And I agree what sir was alluding. Role of surgical treatment has evolved, although aggressive surgical debridement was one considered first line, but there are now mycobacterials which are better, and we recommend a less radical. So there are 2 schools of thought. You look at literature, you will find people who are recommending surgery, mostly Indian surgeons. They are very, very radical nowadays for surgery. I really don't know what is good or what is bad, but we have put some of our experiences here, when to operate. Sir had put it, and I'm just reiterating 3 indications of surgery. Patients who don't respond to medical treatment, maybe we put a rough cutoff of 3 weeks or 4 weeks, who have absolutely no response to pain, means there is something happening inside which is not responding to that medical treatment. It might be vascular, your antibiotics are not reaching, it's not responding, there are abscesses inside, and you have to treat that to bring down the pain, and it definitely works. If there are abscesses which are seen on CT scan, it is not going to be well treated. As I had shown you, expansion of temporomandibular joint, it's not going to respond to medical treatment. And if there is sequestrum, that sequestrum or that bone needs to come out. It is not going to be a purely medical treatment. Failure of medical treatment, that is persisting pain despite good antibiotics, adequate dosage, is the most common indication for surgery. And extent depends on how much is the radiological extent of disease, from very limited debridement to a very extensive debridement. A prognosis, sir had said you need to counsel the patient on day 1. 6 months mortality in our series was close to 13%. 6 months, 13% of patients, they died. Cure rates, if you look at long-term cure rates, at around 6 months are around 45-50%. And most mortalities or more deaths are related to indirectly SBO. They have cranial palsies, they might get aspiration pneumonia, and therefore they get mortality. And some patients do get meningitis or cranial extent of disease leading to aneurysms and rupture and death. So these are our patients. Mostly they are advanced stage. Our cohort is mostly stage 3 and stage 3B and sometimes stage 2. Very, very few. It's difficult to diagnose. They will have just painful itchy ear. Very difficult to pick them as a skull base osteomyelitis as stage 1. So these are the predictors of poor outcome. If we look at our series, we define it as active disease as 6 months. And what are the predictors? We looked at all factors that were analyzed: age, sex, comorbidity, stage of disease, HbA1c at presentation, pain scores, need for surgery, and what treatment was given. Only age at presentation was the significant predictor. More the age, worse the prognosis. And we have seen that patients who have got 2 comorbidities, that is diabetics, and they have nephropathy or they are post-renal transplant, they do better. How do we define cure? It's very difficult. CT scan doesn't revert back to normal, or there will be surgical changes. And same is the problem with MRI. So what we did was we corroborated our pain scores. That is, the patient is clinically telling you I'm better. The pain score was 7. The resident will daily ask you, how's your pain? How's your pain? Initially it was 7 and it is gradually coming down to 2, and it is 1 at end of 3 months. It fairly well corroborates with PET scan. So we have done a study evaluating whether the pain scores or clinical cure was corroborating with the PET scan, there was a very good correlation. If it was clinically resolved, almost all patients had no uptake on PET scan. And if the disease was active, if the patient is saying I have pain, all of them had PET affinity or all of them had PET positive. So probably a good way to monitor the disease, to do a PET scan serially, although practically or financially it might not be viable or feasible, but that's one of the modalities what you can use. But pain will respond if the patient is responding. And it has been further corroborated. Sindhu sent me this, and this article has also quoted our publication. This is a meta-analysis on the utility of PET scan, and they have said that this has a good diagnostic accuracy. This patient was a railway officer. He had come to us from Lucknow. He had a history of some temporal bone trauma 3 years back. No relief with modified radical mastoidectomy, and I had shown you the CT scan. There was lots and lots of sequestrum lying in almost whole of vitreous temporal bone, and this was what the EUM looked like. You could see lots of flaky bone pieces lying in the external auditory canal as well as mastoid. We did drill a lot of mastoid, revised the whole mastoidectomy, took the disease out of whole of vitreous. It was just lying loose, and I will show you probably at end of the video. The facial nerve, it was already paralyzed to grade 6 palsy, and it was lying loose within the mastoid. This was definitely, we did try stimulating it with the monitor, but it was a non-functional nerve. Patient was very happy. In fact, he gets me sweets every time he's coming to Delhi. Was one of the patients which we very proudly cured. And that's his post-operative scan. You can see whole of the vitreous has been drilled out, but very nice outcome. And it came out as fungal. We gave him antifungals for 3 months. So this is one of the widened temporomandibular joint where there were micro abscesses. They made a large post-oral incision, a modified cortical with canal wall down mastoidectomy. And wants to highlight here is that such patients, they require a mandibular condyle to be addressed because disease lies anterior to external auditory canal in the area of tympanic bone, anterior tympanic bone, which needs to be drilled out and also address the TM joint or temporal or mandibular condyle at level of its insertion. One point I wanted to make is this is not the disease of mastoid. Sir had repeatedly mentioned in his presentation that you should not be doing mastoidectomy, and this is the reason why. This is one of the patients, I have mentioned history in next slide, who had been radiated for a cancer of buccal mucosa very many years back. He presented to us with pain. Possibly some other hospital, they thought that this was actually a radionecrosis because patient had undergone a radiation, but he had very typical presentation. Look at the external canal. Look at the granulations. Look at the EAC that is fairly inflamed. Look at the pseudotympanic membrane that has formed. Look at the attic. You can actually see probably the outline of facial nerve. And this area, if you compare with this area, is fairly healthy. So this is the disease of floor of external auditory canal. This is the disease of hypotympana in this region. And probably that will make it not a case for facial nerve decompression because disease extends to the facial nerve canal, to the stylomastoid foramen, deep to this region. So it will involve the facial nerve in this area rather than in this area, which will be the conventional areas where we are decompressing the facial nerve. Another patient, I had shown you the scans previously, is 59 years, right otalgia and hearing loss for 18 months. He used lots and lots of NSAIDs, added paracetamol for 6 months, diabetic, multiple small procedures, admissions for diabetes-related issues, kidney disease also. We did a debridement. I had shown you this image. This side was debrided, very, very radical debridement, except for a small tip cell remaining here, cavity obliterated with the possibly fat. I don't recall that. And he was very, very pain-free after for quite a long follow-up. And he came back with other side lower cranial nerve palsies. So a elderly patient who had got many comorbidities, uncontrolled diabetes, CKD. This patient, we did not surgically intervene. I don't know whether we were right or wrong, and was a case for medical treatment only, and disease was crossing the midline. So there are some take-home messages. It's a radiological and clinical diagnosis, although you might need to do a biopsy for sampling this. Treatment is medical with broad spectrum antibiotics. That's the current recommendation through this forum. Patients not responding to treatment, having abscesses or sequestrum, they need surgery. And surgery needs to be tailored to each individual patient. Risk to be weighed with benefits. A patient who is very bad clinically, who will not tolerate your surgery, don't be very heroic. In that, patients need staging very, very accurately because lower stage disease responds better to treatment. Lower cranial nerve palsies, patients who are coming to us, they are stage 3, they do badly, they do poorly. And clinical cure correlates well with PET scans is the message that I give. And I'm very impressed with this article, which says role of intuitive knowledge in diagnostic reasoning of hospital specialists. It's gone beyond saying the concept of evidence-based medicine. They are saying that there is something to intuition, which I feel that current day physicians are lacking. Sometimes intuition tells you that how this patient is going to behave. And I probably have grown older, so we have started to realize that also. Thank you.
That's almost a crash course on the entire subject. I think we are progressing well. We are getting scientific knowledge, not just opinions as to what works, what doesn't work. Needless to say that it's an evolving topic. Our knowledge will keep growing as we see more number of patients. That is the whole point of doing such discussions where people can share experiences. So do you feel there's some question to be asked?
Kapil sir, that was a great presentation, definitely. But I want to know can we do PET scan in the initial phase? We are always talking about getting PET scan at 3 months when we want to do the follow-up of the 6 weeks. Because sometimes like we look at the ESC, we get minimal granulations. And we get a PET scan and maybe there are a lot of soft tissue density in the cortical.
What are you looking at in PET scan? What information do you want from that scan?
Maybe the area where we can maybe take a better biopsy and better cultures. Is it possible?
PET scan is not a spatial scan. It doesn't tell you about area.
Combined MRI.
Very expensive, but yes, that thing can be looked at. But if you look at the PET scan or the values of enhancement on PET scan, they are not very accurate. Even the cancer specialists, they don't look at
SUVs.
For diagnosis. If SUV is 100 or 200 or 500, they don't look at that this is a infective node, this is a cancerous node, this is a positive node. This doesn't work that way. So I don't think that diagnostic accuracy of PET scan and from where to take a biopsy, it is not an anatomical scan. It just tells you that this area is lighting up, but there is something bad in that. I think PET scan should be respected and looked at only for that much information. It
only
is not
for a follow-up. So you say for a PET scan?
I will not do PET scan for initial diagnosis. It is not going to add any information. It will tell you that something is lighting up there. Now it is up to your judgment whether it's infection. It can be maybe cholesteatomas also light up. Maybe cancers also light up.
The controversy we are here that we are missing malignancy. So if something is lighting up more, it's
PET scan
really high.
PET scan tumor from infection.
Yes, but
so if it is a clear tuberculosis,
yeah.
PET scan is not going. He is not going to report that this is a cancer. This is not a tuberculosis, and that is one of the major pitfalls in PET scan. We have overdiagnosed lung nodules as PET avid, and we found that they were eventually tubercular, and patient is delayed for 3 weeks, 4 weeks. Uska EBUS हो रहा है, उसकी bronchus से biopsy हो रही है, उसका lymph node से sampling हो रही है. Eventually, it is tuberculosis, which is probably rampant so much in India. So don't take PET scan for that diagnosis. It is good for follow. Patient otherwise cured है. आपसे पूछ रहे हैं तो उसका दवाई बंद कर दूं. Sometimes you don't have an answer to that question. Pain is much better. Occasionally, 10 days back, I took 1 paracetamol. Now it's very good. So you do a PET scan, you can be doubly sure, yes, now you can stop your treatment. Probably only that much follow.
You can get a similar information just by doing CRP, ESR along with the pains.
They are not coming down to baseline. That's what I was.
Not baseline, but so the fact that it is.
ESR very typically will follow a trend. Patient comes to you, it will be 120. Second reading 85, third reading 95, fourth reading 70, then again 80, then again 45, and it will be 45, 45, 40.
30s range. They come to the 30s range.
So I've not been able to establish a cutoff. That is what I wanted to say, and Sindhu agrees with that. We have not been able to establish a cutoff that below this it is okay, above this it is disease.
But take it along with CRP. CRP very often falls to normal levels.
It will decrease. It will decline for sure.
No, but CRP does come down to normal levels. That's been my experience.
Yes,
you've done a fairly exhaustive.
Maybe
in my experience, it's always come down.
It will tell you that you are on a right track. That's what the maximum information that we have got. Can't base our decision based on that probably. So good response to ESR CRP and maybe a negative PET scan and a good happy patient that हाँ मेरा
Pain response. I use only 3. Yeah.
One more question, please. Like, as you said, most of these patients are immunocompromised. Like they will,
also.
all are like that, and many of them will have deranged kidney function. So the radiologists say that we can't do FETRA study. So, like, is it enough to do like plain MRI CT?
We can do a plain MR also because MRI we generally do to evaluate the extent of disease
Yes.
on where the disease is going, and if it's clinically suggestive, if CT is showing these features, patient is diabetic, he's an elderly, you have ruled out a cancer, एक ear से biopsy ले ली, nasopharynx side से biopsy ले ली, and they have said it's not a carcinoid, then diagnosis is fairly straightforward. Other things they will tell you. We have had occasional lymphoma, we have had occasional tuberculosis, we have had occasional malignancy, nasopharyngeal carcinoma, adenoid cystic, all these things are ruled out, then you can treat on these lines.
Our contrast is actually quite safe.
Yeah.
It's really suspect. So when you want to get
Yeah, sometimes they are
still
still skeptical. In kidney compromised patients, they are sometimes skeptical. Yeah.
What's your experience with ceftazidime?
I do give them, but my first line is our piperacillin. But sometimes, occasionally,
It's a good drug. Photam is a good drug, but it has to be culture guided. Mostly either meropenem or piperacillin tazobactam. Second line will be photam or fosfomycin.
meropenem का फायदा ये है सर इसके oral alternatives आ गए. You can give meropenem and you can.
Meropenem is
No, I think meropenem is not in meropenem. We have that discussion.
We got
Dr. Ankita is there in that discussion. Just have it now.
Have the right.
Just one correction.
Yes, sir.
Meropenem is not an oral analog of meropenem.
Correct.
Its coverage is not.
It's definitely, but it is not.
Its coverage is very
different.
Please, ma'am. We don't use much of meropenem.
Yes, I agree. So after this wonderful session, I invite Dr. Ankita. She's our infectious disease specialist. One of the most wanted sessions for today. I think we all are very keen to learn about the antibiotic and maybe the drug protocols and controls as well briefly. Guide us in this specific pathology. Thinking of both the drugs, their administration. Sometimes we don't discuss too frequently. It matters a lot in our special patients of diabetes and renal disease patients, as well as the length of treatment, which more often we talk rather loosely about as to how it should be.
So we can have an active discussion, whatever questions, because I have thought as an IT person, but we need to, I care to answer on the ELT perspective also, whatever.
Yes.
So.
You can.
Common dilemma that we have in our practice, that what is the bug that we are treating here? That the imaging is suggestive of SBO, the patient comes in OPD with headache, fever is most commonly missing in patients who have skull base osteomyelitis, and most common symptom, as Dr. has mentioned, that it is headache, and sometimes associated with otorias or some chronic sinus infection is there. So what kind of bug we are suspecting so that we can tailor the antibiotic accordingly, and the right choice of antibiotic is there. So to start with, we know it's not very common condition in our practice. When we see skull base osteomyelitis, it's a complication mostly related to skin, to ear and sinus infection, and mostly seen in patients who are diabetic, elderly, immunocompromised. Whenever we are dealing in a diabetic patient, malignant otitis externa, partially treated, many times I see in my OPD with Pseudomonas infection, or sometimes it's a case of malignant otitis externa and the patient is diabetic, all cultures are negative. Ear swabs do not reflect the exact pattern, exact microbe which is causing the infection. So first line is usually directed towards Pseudomonas infection that we discussed. A common classification is typical and atypical. As if I talk about bugs here, typical is mostly associated with ear infection, and we yeah, automatically changed it, right? So typical is mainly associated with ear infection, and in diabetic, as we mentioned and we discussed in previous lecture also, Pseudomonas is an important culprit bug. Many a times there is associated meningitis. So what is the choice of antibiotic that was being discussed in the last session? So I believe we should have an antibiotic, and it's mentioned in most of the recommendation that should have a good CNS penetration and the bone penetration. So, and also the doses of antibiotics has to be higher because we need the concentration in the bone, and skull base, we know the vascularity is very highly compromised. So there is the dose of antibiotic, which commonly I see in my practice when the patient gets complicated. The doses of meropenem is given 1 gram BD or TDS in general practice because to assure that the patient is taking it well at home. Because most of the time it is OPAT care as it's a prolonged antibiotic and patient is not admitted in hospital. So the doses of antibiotics has the dose of antibiotics has to be 40 mg per kg and 2 gram IV TDS if I talk about meropenem. Monotherapy with ceftazidime, if we don't have a culture proven case and we are suspecting Pseudomonas, is not at all recommended. But if we are going with ceftazidime, it should be combined ideally with a fluoroquinolones, because here what we need is we need something that has to go in bone with good concentration, and FQ has good concentration. Ceftazidime again has a good blood-brain barrier penetration. So it makes this combination makes a good choice without any added toxicity when we talk about aminoglycosides, because we know we require good monitoring of renal functions when we give prolonged aminoglycosides, and most of the patients don't tolerate it for the long duration that we want to give in such patients. So there is some problem with it, automatically changing. So, this is what I talk about Pseudomonas infection. But when we talk about atypical SBO, it is mainly associated with, it's not always Pseudomonas. Atypical means it's not related to the ear infection as such, and it's unrelated to the local source of infection. Here we see a lot of fungal infections, which come, I had cases of NTM infection also. During biopsy, it was diagnosed, and there can be staph aureus, which can be a culprit in this. So it could be different GNBs, staph aureus, and fungal infections, which can come in picture when it is atypical SBOs. This is what the common scenario we are talking about. And most of the time, it is not always possible that we get a biopsy of the or the culture proven cases. So we have to see what the lateral findings we are having, like the biomarkers. I had cases where all the cultures were negative, everything was negative. The superficial cultures from the ear swab was negative. There was a discharge, and the patient had a high beta D glucan level, and beta D glucan level, which suggests that it could be a fungal infection, invasive fungal infection. So this marker itself, and he was he came from Chandigarh, and this patient was receiving a lot of antibiotics, including oral quinolones from longer duration, no response to treatment, and the subsequent MRIs had shown that it is worsening. So suspecting that I'm not dealing with something which is bacterial, send this fungal biomarker, and this came positive. So treated this patient now, a patient with echinocandins, and we also need to understand that plain echinocandins will not have good penetration in bone. So we need to add some azoles here, again, which has good penetration in the bone also, in the CNS also, because echinocandins has to be on a very higher doses when we are treating with echinocandins, and we want that to penetrate in the cross the blood-brain barrier and treat the local associated meningitis also. So, so that challenges is overcome when we combine it with a good azole therapy.
What about?
For suspected fungal infection, yes.
What is that?
So that depends upon what fungal I am suspecting. So when it is when there is no associated sinuses involved as such, and beta D glucan is positive, galactomannan is negative. Galactomannan and the features are not suggestive of any mucus as such. So in that case, echinocandins becomes a choice when the usual pathogen we are suspecting could be a candidate. And amphotericin B has a good blood-brain barrier process. Liposomal has to be given on higher dose. But this also depends upon what is the overall clinical picture of the patient, what fungus I'm suspecting. Mucor is usually seen in patients who are diabetic or having ketoacidosis or patients immunocompromised with a good sinus infection. There's a lot of blackening. In fact, the ENT surgeon tells us what was the perioperative finding that time. It's a lot of necrosis.
What about aspergillosis? But
Aspergillosis also, yes, aspergillosis will have a galactomannan also positive in that case.
Like, so what's the drug of choice?
So aspergillosis, if we are treating with this SBO, voriconazole is a drug of choice. But again, the problem is voriconazole is a static drug. So if the patient is not responding the way we feel that the patient response should come, then there is a salvage thing that we add ampho or caspofungin.
The thing is, the Candida involvement in the central skull base osteomyelitis is much less compared to aspergillus. I think the most commonest
Would be aspergillus.
will be aspergillus.
So there should be the markers. I was talking about the biomarkers, that what markers are coming positive. That leads to the diagnosis that we are going with.
What is the sensitivity of these markers?
Usually around 70%, 75%. It's not very high, but overall picture has to be considered.
But galactomannan will only support aspergillus. But if you're thinking in terms of rhizophus, then this will be negative.
Yeah.
So you're again back to the clinical aspect of.
So it's a patient.
Even a biomarker would fail there. So if you're suspecting a fungal, you would want to cover, because the problem is if you've got a mixed fungal infection and you're giving covering only aspergillosis, and there is a possibility of rhizophus. You've not given liposome.
Mucus is so flared up, usually with a lot of involvement in the surrounding tissue and a lot of necrosis. Usually the radiological imaging itself suggests that it's a highly flared up lesion is there, associated with the time, yes. One. And yes, the biomarkers both can be negative in case of, so if we have a gluten positive and galactomannan negative, and there's no sinuses involvement, aspergillus IgD, I'm talking about biomarkers. Aspergillus IgD is negative. So then you think more of Candida. Candida choices are this. When we are talking about aspergillus choices, it's mostly voriconazole, but yes, sometimes salvage therapy has to be added. And when we talk about mucor, so again, the mucor, I had a slide also here last. So again, in mucor cases, so mucor, initially, all the results, all the recommendations are related to liposomal amphotericin B, that we have to give on a higher dose, liposomal amphotericin B, and the durations is also not very defined. Some says it could be 6 weeks, 8 weeks, 10 weeks, 3 months, and practically also we see that patients require longer therapy, and the tolerance compromised. These patients are mostly diabetics, renal compromised, so hypokalemia and kidney derangement is commonly seen. What to do now? So now isavuconazole has shown non-inferiority. 2 trials are there.
Unfortunately.
So isavuconazole, so has shown non-inferior and good tolerance. Isavuconazole is available. That the cost is a challenge. Posaconazole, but
where you're not sure it's a mix, you're not very sure it's not.
Absolutely.
No, so I want to add here, posaconazoles to attain and manage drug levels is challenging. So now we are treating an infection which requires a good penetration of antibiotics. Levels cannot be compromised. So posaconazole absorption is erratic. We know that. That's why drug levels has come into picture, that we need to check. It's not commonly available drug levels. Some companies are doing, I don't know how much.
Biggest challenges in the post-transplant. No,
it's absorption.
So the measuring is very, very difficult. It is extremely expensive to measure. So probably liposomal wins out ultimately.
So no, that's what I want to add here. That liposomal, after the good induction phase, you can switch the patient to oral isavuconazole. And initially also, it's always isavuconazole doesn't have the erratic blood levels. So initially, after good induction of isavuconazole, like 2 doses, if you give IV, the patient is hospitalized and then switch to oral. That doesn't never compromise. So it's my practice that I usually give IV induction initially. The patient is admitted and then switch to oral. Literature still has to come up with this, that whether IV induction is required or not. But this drug is promising. It's not only for combined infection. So we want good levels when we are treating bone infection. So that is compromised when posaconazole is there because absorption is erratic. This drug.
Do you have any latest comparison between sulfonazole and sulfonazole?
Sorry, I have to see. I have to see that. But this.
There are concepts.
Yes.
Syrup, there is a delay.
The tablet.
Tablet is there.
The tablet ones, they are supposed to be better. Syrup really has very.
So the thing is, whenever you are giving syrup to the patient, it is always important. Nowadays, we don't use syrup.
With a fatty
But only, and it can be given irrespective of the. But still, the levels of posaconazole is.
not reliable.
It's not reliable. It's very.
So what something going to do, generally you will give for 3 months as well.
So that was being discussed, the clinical recovery.
How much is it cost?
So I usually, nowadays, a lot of companies are coming. So cost are having a lot of variation. The earlier one, which is the standard, that was patent initially, isavuconazole, usually comes in around 8,000. It's very costly. It's very costly. But when we compare with ampho doses, so then it doesn't look that costly and it's better taught.
During the COVID, we had initial all these look at patients, initially on liposomal amphotericin. They were put on maintenance. We had one group going on bisoconazole, other on posaconazole. In fact, don't think we ever really measured the blood levels, and except for liver subtypes levels and GI side effects. Posaconazole is really very top. Your experience will be
Yeah, tolerance is not a problem with posaconazole. So drug levels is again, it's not very commonly available to be
At that time, it was a question of choice. We didn't have a choice.
Even now.
There's not no. I had picked up the entire country's isavuconazole. I had picked up because I kind of anticipated, and there was nothing else available. We just picked up the entire.
That's why we were short of isoconazole.
So I had the stock. So
What is the current role of posaconazole in this fungal mucormycosis?
So mucormycosis, it's basically like after the induction, it's in the maintenance therapy, which is now again recommended. It's a standard recommendation. Literature has to come up.
Given posaconazole after discharge on oral, we can discharge the patient.
Yes, we can definitely.
I mean, what is the efficacy of posaconazole?
Failure rates in common, like if I talk about rhino or vital mucormycosis, is not that high. I'm talking about bone lesions. So bone lesions, when we are talking about osteomyelitis, the levels cannot be compromised because we know whenever we are treating bone, CNS infection, infective endocarditis, we require higher doses of antibiotic to have adequate penetration. So this is why it is very important that we know what is the involvement here. For sinuses,
Can you summarize when to give amphotericin, when to give voriconazole, when to give posaconazole, and when to give azathioprine?
okay. So
For clarity.
yeah, so whenever we are having a cases of suspected fungal tissue, it's not tissue proven, or it's not we don't know which species it is. Broad spectrum liposomal amphotericin B is always the first choice. Is always the first choice that you give a good induction phase there. The doses should be high, at least 5 mg per kg, but can go up to 10 mg per kg also, depending upon the tolerance of the patient, definitely. Importance is that whenever liposomal amphotericin B is given, very common error is the administration of the drug. That it has to be, it should be given in D5, but it has to be filtered there. There is 2 times it has to be filtered before giving to the patient, and this decreases the toxicity. That filter needle is there with the.
it's
there with this.
In fact, reconstituting itself is the biggest problem.
And giving it through BT sets again, it adds an added filter rather than giving through IV set. So I prefer using BT set for that. So this amphotericin B should be the first choice here. If you have a diagnosis that it is made that it is aspergillus SBO that is being treated, voriconazole is a drug of choice. Not responding adequately, then this, salvage therapy, either add ampho or you can go with caspofungin with this. If it is mucor, again tissue proven, then it has to be ampho. And as the patient is stable, you want to discharge the patient. It is not osteomyelitis, sinus infection only. Posaconazole is good, no problem there. But if we are treating SBO, I think more literature has to come up so that we are more confident. It's in my practice, I am using isavuconazole. I recently had a patient who have came from Dubai, somewhere from Arab countries, and this patient has been treated in Delhi hospital only with liposomal amphotericin B. There for surgical debridement, CNS involvement was also there. Was on maintenance posaconazole, and this amphotericin B was ongoing with lot of AKI related issues, that he was badly controlled diabetic. So this patient, since he was not improving the way it should be, after receiving 4 months of therapy that he had received, I had switched to isavuconazole. Right now he's ongoing treatment. Now he's talking, accepting orally. Lesion has become better. In subsequent scan that we did 1 month later. So this patient was already on POSA and lipoampho. I also continued with lipoampho initially. Bridged to isavuconazole, as I saw that the symptoms, there was a lot of crusting initially, and on and off nasal bleed was also there. This patient, that has resolved. So then switched to monotherapy of isavuconazole. Right now he's in follow-up. And
how important do you think the issue is with biofilms with pseudomonas?
Biofilms, yes. So biofilms basically forms on artificial surfaces. So if any artificial surface is there, pseudomonas, staph, these are having strong biofilms. So now we have to choose an antibiotic. So anybody has used polymyxin B for drug-resistant pseudomonas here?
Only topic. I've never used topic.
Polymyxins has good activity on biofilms, but they have very bad penetration in the bone. So since we are discussing osteomyelitis, it's only around 30%. So that biofilm formation can be there on artificial surfaces, very strong in pseudomonas, dead tissue, sequestra. So that there comes the role.
The presence of biofilms is resurrecting the interest in doing the debridement. Because of biofilms, your antibiotic penetration
is not going to be there. That sequestrum is there. So dead bone formation, and it's not going to be clear. But there are certain antibiotics which works on biofilms also.
Next,
Look at deeper.
So to isavuconazole, ampho, and isavuconazole has to be there.
No choice.
No. The only thing we have to remember, since we know that the SOS has a erratic blood levels any of the time, there should be an overlap. Whenever you are planning to switch to oral, there should be overlap with ampho and posa. 5 days. On an average, steady state concentration takes 5 days. 5 days steady state concentration takes 5 days for posaconazole. At least 5 days before you are planning to stop ampho, it should be there. Posaconazole should be there, so that this overlap is there and the levels are maintained before the patient switch to possibly oral. So these just we discussed. So key points here to remember is we have all discussed this. Duration is as per recovery. So there are many literature, and in practice also we see sometimes in SBOs we require 16 to 20 weeks also of antibiotics. MRI never shows complete resolution. Most of the time we have to do some comparative study from the last section and this section and other inflammatory markers, clinical recovery, to decide for the patient to stop antibiotics. Drug levels wherever required. Voriconazole drug levels are available. The usual recommendation is between 2 to 3 that it should be maintained. And the giving voriconazole has to be empty stomach, preferably like 1 hour at least before food, so that absorption is not erratic. And monitoring of side effects and outpatient antibiotic therapy care is what is the need of the nurse. Whenever we are giving prolonged antibiotics. Thank you for your patience. So any questions?
A lot of discussion went towards fungal because it's been bugbear. But coming back to, you said use of fluoroquinolones as an adjunct. Unfortunately, in our setting, we've never encountered pseudomonas, which is in the hospital scenario, which is actually amenable to fluoroquinolones, not in our country. So what you, because like he was quoting the study that was UK based, was it? So UK, we used to very typically treat everyone with ciproflox and it worked. It worked. You could actually discharge the patient for on that duration. But in India, we do not, and especially
That's why
How many headache people are blocks sensitive?
all resist. It's
So
all.
that's-
it
that's
is-
what
So
the-
that is
that
the thing.
that is where we are coming from.
So that is the thing why monotherapy with quinolones, especially if SBO is there, not for just ear infection, is usually not recommended. If it is culture based and you are going with ceftazidime, then you can go with along with fluoroquinolones.
But you supported
But that
of it as an adjunct. Is it effective? Because you are.
That is culture based.
But culture is
Culture is very.
No, if it is culture based, if it is culture based, then and it is carbapenem sensitive, then you can go with carbapenem. If it is carbapenem resistant, then you go for the genetic testing. That is possible. Carbar expert testing is possible, or the synergy test is possible, and then you can choose whether you can combine it with avibactam. Estronam also is a very promising drug for Pseudomonas. Like most of the time, we don't gain sensitivity. I'm not talking about Estronam avibactam. It's Estronam. But the problem is with Estronam is that it can lose the efficacy very fast. So you should never give it as a monotherapy. So, or if it is highly resistant strain of Pseudomonas, so you can definitely request the lab to have a Estronam.
We get such a sensitive code as resistant to all the antibiotics,
including
except
cholesterol.
cholesterol, that too intermediate.
Yes.
So basically, as per the guidelines right now, so colistin is never reported sensitive.
Yes.
So if
that is
the
the
lab
my kind of
has the report that it is intermediate, so we take it that it is sensitive. Now the Pseudomonas is usually sensitive to polymyxins. Challenges that we have is we have to treat a bone infection. We have to have an antibiotic which has a penetration in bone because the area has to be infiltrated with the antibiotic. And we have to give a long antibiotic. So initially, to decrease the bacterial load, initially 2 weeks or 4 weeks it can be used. But definitely we have to have an antibiotic which has a penetration. Here comes the role of having a genetic testing. If that is available, Carbar or this thing. If it is NDM, NDM is there, you combine it. It's a genetic test of the bacteria that we get the report. We request the lab and we get the report.
What we did, like one of the patient had very resistant pseudomonas infection in the ear, and his ear was not dry. And the report was cholesterol intermediate sensitivity. So because cholesterol drops are not available, so we actually made cholesterol drops from the wire, and we started her on cholesterol ear drops, and she. So I mean, many times, I think we have tried it for 3 patients now.
Out of the box.
No, we have also done, but problem with that is he may develop resistance to cholesterol if required intravenous.
Because MICs are not standardized.
Right.
So this is the problem that we are.
Spreading infection across the bone.
Then obviously, ideally,
And meropenem I had seen a lot of prescriptions coming with meropenem 1 gram BD, so that patient takes at home at this doses. And then subsequently he's not improving, partially treated, not improving. Then he comes for the opinion, and then I see that it is there. Now the bug is resistant. So now I have to go with ceftazidime, avibactam, estronam combination. Nowadays we also have estronam, avibactam combination. Not very added advantage to give monotherapy of estronam, avibactam. I have to add either meropenem or ceftazidime. So it's either ways we have.
But resistance is not happening because they are treating infection. Resistance is happening because of prophylactic use. I've seen surgeons after temeroplasty, they are giving 1 or 2 weeks of IV meropenem.
That is
Prophylactic is just.
Yes.
And partial doses, you are giving less doses, and then it
It is 2 grams PDS.
is
60,
40
70
mg, 40
mg per kg.
40 mg per kg. Let it be available in India. It is coming from, you know, the cost. So asking the patient to take 6 weeks, 8 weeks epidural is challenging, but it is good for Pseudomonas.
Very good.
So Ravi sir would now essentially summarize our sessions we've had. Apart from that, also, I requested him to discuss especially the forgotten part of the disease that we're talking about, how to rehabilitate cranial nerves, this particularly troublesome pathology. whether or not we operate, whether or not we give medicines, antifungals, antibacterials, the very important part of long-term management, long-term continuing care, and swallowing and lower clinical management is a part that can essentially differentiate life and death for these patients. It's very pertinent to discuss. And I think after Sir's session, she briefly summarize. Apart from that part, we quickly get on to our panel discussion. We have two very interesting cases I want to talk about with the experts of.
So I think most of the things have been already discussed, and I think I will be just doing a repetition, and I will try to skip the things which have been already discussed in detail. Like we have already discussed many of the things, but I will just try to summarize the things. So necrotizing otitis externa is the correct term. We should not be using malignant otitis externa, as Sir has already told. And in case there is an involvement of bone, it becomes necrotizing. If it has not involved the bone, it is just simple otitis externa. And because depending on the involvement of temporal bone and then middle part of the temporal bone as well as the central skull base, it can cause skull base osteomyelitis, right? Typical and atypical, Sir has already discussed, so I will just go ahead. So this was a systematic review of the diagnosis and management of necrotizing otitis media, and it's very recent, 2023. So I will be summarizing this systematic review, which consists of 70 articles, and it involved 2,274 patients, right? So median age of the patient was 69. So it is a disease which is seen in elderly patients and more common in males. Again, the same finding which Dr. Kapil has earlier told. And the incidence was around 0.2 to 1.9 cases per 1 lakh population, right? And 10% patient did not have any immunocompromised state, right? So that is also very important. Many times you will not find any immunocompromised condition. And these patients are usually elderly patients. So what has been described is that probably it is because of the decrease in the cellular and humoral immunity with age. So as you age, there is a decrease in immunity, and that actually predisposes the patients to skull base osteomyelitis, right? Another important point which this paper actually highlighted, that 11 to 18% of the patient had recent ear instrumentation. These were all elderly patients who had gone to an ENT surgeon for wax removal, and the surgeon has actually done syringing, or he has done some instrumentation using a probe, right? And these patients actually developed necrotizing otitis externa later on, right? And probably because of the fact that the water makes the wax less acidic and it lowers the lysosome content of the external canal, making it susceptible to pseudomonas. So one of the etiological factor is ear instrumentation and syringing, right? And this is an important finding of this systematic review. And diagnosis of skull base osteomyelitis is usually delayed by an average of 6 months. And again, it is because of lack of suspicion and lack of clear-cut diagnostic criteria. If there is an increase in incidence of SBO, so as we have increase in the aging population, also with the increase in diabetes prevalence and increase in awareness and better diagnosis, we are having lot more skull base osteomyelitis patients in our institution, in our hospital. And this is one of the hospital in UK where they have actually seen the number of patients has increased over the last like 10 years. Okay, so I think I'm not going to the details of this factor. We have already discussed pathways of spread. Also, we have almost discussed histopathology. Okay, so nasopharyngeal carcinoma, again, Dr. Kapil has already emphasized. It is one of the differential diagnosis which we need to consider. And post-radiotherapy patients also. Patients who have received radiotherapy to head and neck area, basically the skull base area, may present with skull base osteomyelitis. Okay, clinical presentation, I think I will not go into the details. So this was a coherent treatment diagnostic criteria. These are basically major criteria and minor criteria, and we need to have all these major criteria to diagnose skull base osteomyelitis, right? So pain, which is very, very important, edema of the canal, granulation tissue, micro abscesses when surgical intervention is planned, positive technetium scan, and lack of improvement with local treatment for more than 1 week. So these are the major criteria, and these are the minor criteria included diabetes mellitus, cranial nerve involvement, positive radiograph, debilitating condition, and older age. So this is a older criteria, but we have a newer criteria which is there in the recent Scott Brown. So this is the latest 9th edition Scott Brown, which has this consensus diagnostic criteria for necrotizing otitis externa, and it actually includes the signs and symptoms, the pain, investigation, duration of symptoms, and risk factors. Right. So we have edema of the canal, otorrhea and granulation tissue, otalgia and nocturnal otalgia. Then we have in the investigation, we have external aortic canal granulations. On microbiology and histopathology, then we have positive CT scan and positive MRI. Duration of symptoms for more than 2 weeks, and at least one risk factor for impaired immune response should be there. And again, these are the basically the same diagnostic items have been actually defined by the consensus guidelines. Investigations, I think I will just skip this part. I will skip the radiology part also. One of the things is that PET scan has a good sensitivity as well as specificity for diagnosing skull base osteomyelitis. Right? So as well as for diagnosis, as well as for follow-up, we can actually use PET scan. Treatment, I think I will just skip this part. This is again a table which is there in the latest edition of the Scott Brown. I will skip. So what is the role of surgery? It is biopsy, local debridement and drainage of large abscesses, removal of bony sequestrum. Surgery rarely results in clinical improvement, and disease progression, including worsening of cranial nerve palsy, can occur. Right. So this we have to be very clear. Inherent risk of operating frail, already compromised, immunocompromised elderly patients, and complete disease clearance is almost unachievable in all the patients. Complications. So Dr. Sikka already told about pseudoaneurysm, which can happen, venous sinus thrombosis, arterial pseudoaneurysm in the skull, internal carotid artery pseudoaneurysm can happen. There can be abscess, infarction, meningitis. Then we can also have extradural, subdural, and brain abscess. And so these patients might require surgical intervention by interventional radiologist to treat the pseudoaneurysm, or by a neurosurgeon to drain the abscesses. Hyperbaric oxygen, though this finds mention in the literature, but there is no clear-cut evidence that hyperbaric oxygen is therapeutic in the management of skull base osteomyelitis. People have been using HBOT, and it is supposed to promote angiogenesis and osteogenesis. But as far as evidence is concerned, there is no good evidence to use HBOT. When to stop antibiotics? So there are no criteria, clear-cut guidelines to define when to stop antibiotics, but subjective clinical relief, improvement in ESR, PET-CT with disappearance of the lesion, and normalization of gallium scan. So gallium scan was earlier used to basically follow up these patients, but this has been totally replaced by PET-CT now. Right? So we can actually do a PET-CT and see if the lesion has disappeared on PET-CT, we can stop the drug. So now we come to the management of nerve palsy. So there can be almost all types of cranial nerve palsy involvement in skull base osteomyelitis, but the lower cranial nerve, the jugular foramen, is very commonly involved, right? So 9th, 10th, 11th nerves are very commonly involved, and there can be involvement of the 12th nerve. There can be involvement of the 6th nerve, right? So the abducens nerve and the 5th nerve, right? So petrous apex involvement can lead to all this, right? So lower cranial nerve involvement can cause severe dysphagia and swallowing problems, and patient can have voice problems also, right? So what are the causes? Because it's a high lesion in the skull base, the whole of the vagus nerve is involved, including the pharyngeal plexus, right? So it actually causes paralysis of the pharynx. It can also cause paralysis of the soft palate, it can lead to paralysis of the vocal cords, right? So it's a high vagal lesion and it leads to complete pharyngeal paralysis, velopharyngeal insufficiency, vocal cord paralysis. There's an anesthesia of the vocal cord, supraglottic anesthesia. Patient has a lot of aspiration. There's a reduced laryngeal elevation and there's a impaired opening of the upper esophageal sphincter. So all these problems are there when you have all the three cranial nerve palsy, right? So what is the management, right? So the surgical interventions can be done at various levels. So one is the velopharyngeal closure. So when there's a soft palate palsy, the velum is not able to close completely and there's a gap and patient has a lot of nasopharyngeal regurgitation, right? And so this has to be treated, right? Plus there's a reduction in when you have a hypopharyngeal palsy. So one half of the hypopharynx is paralyzed, right? So the piriform fossa actually bulges and it is a relaxation of the piriform fossa on that side. And so the food actually collects in that part of the piriform fossa in hypopharyngeal palsy. And what you can do is basically you can actually reduce the size of the piriform fossa and augment this part of the hypopharyngeal wall with some tissue, right? Then you can actually do, because the upper esophageal sphincter is not opening properly, you can do cricopharyngeal myotomy. For vocal cord palsy, mid-dilation thyroplasty or injection laryngoplasty can help. And because there is a laxed vocal cord, there's a lot of aspiration. So we can tense the vocal cord by doing arytenoid adduction, or we can combine the procedure with cricothyroid approximation. So when you do a cricothyroid approximation, the vocal cord becomes more tense and it prevents aspiration, right? So these are the surgeries which can be actually performed for treating the lower cranial nerve palsy, right? So first is the velopharyngeal insufficiency. You can do a pharyngeal flap. For reduced pharyngeal contraction, you can do a hypopharyngeal pharyngoplasty. For vocal cord palsy, you can do a vocal cord medialization or arytenoid adduction. For upper esophageal sphincter, you can do a cricopharyngeal myotomy. For esophageal dysmotility, also you can actually do a cricopharyngeal myotomy. Insufficient laryngeal elevation, you can do a laryngeal suspension, right? And for silent aspiration, ultimately, if the patient is having aspiration and you have done these surgeries and still patient is having aspiration, there is no other option available than tracheostomy. So you have to do a tracheostomy to prevent aspiration. And many of these patients can actually have severe aspiration and can lead to death, right? So I have not done a pharyngeal flap repair. Frankly speaking, this is what I could gather from the literature. So normally when you do a pharyngeal flap surgery, it is done in midline. So you base a superiorly based flap, a U-shaped flap, and it is actually sutured to the soft palate, right? But in case of a unilateral pharyngeal palsy, you have to raise the flap on the paralyzed side, and the other side will be open, and that will be actually for the respiration from the mouth, right? So the lateral pharyngeal flap is used to augment the velopharynx, right? Hypopharyngeal pharyngoplasty again. So what happens when there is a pharyngeal palsy on one side, the food actually pools on that side, and because it is not contracting, it is not able to. The patient is not able to propel the food towards the cricopharynx, and there is a bulge. It's just like having a diverticulum like thing. And what you do is basically you resect this excess portion. So this is the schematic diagram which I found on the net, and basically you excise the constrictor muscles from the oblique line of thyroid cartilage, and then you remove the posterior part of the thyroid cartilage and remove the excess of the piriform fossa mucosa, right? So this is basically removed and you sutured it, and then again this pharynx, this cricopharyngeal muscle is basically deposited back and giving more basically augmentation to this part of the pharynx, right? So that is hypopharyngeal pharyngoplasty, and it will actually improve the passage of bolus from the hypopharynx into the cricopharynx, right? Then you can actually do a type 1 thyroplasty to medialize the vocal cord. So medialization will actually improve the voice also, plus it will improve the aspiration part also, right? Both the things can be had. So I will not go into the details of the surgery. Then you can do a injection laryngoplasty. And lastly, because the cricopharynx is also supplied by recurrent laryngeal nerve, and that is also paralyzed. So to relax the cricopharynx, you can do a cricopharyngeal myotomy. This can be done through the oral route, right? Through the which is laryngoscope, and you just have to cut the posterior part of the cricopharynx, right? So you go into the cricopharynx opening, cut the mucosa till the muscle. You have to cut all the muscle fibers of the cricopharynx, right? So that will improve the function. Arytenoid adduction, if the patient has a very floppy vocal cord, even midline is not completely helping, and there's a large posterior glottic gap, you can combine the procedure with arytenoid adduction, right? So when you pull the arytenoid, so this is the vocal process of the arytenoid, and this is the muscular process of the arytenoid. You pass a suture through the muscular process of the arytenoid and pull it anteriorly. So when you pull it anteriorly, it is rotated medially. The vocal process of the arytenoid is rotated medially, and you close the posterior glottic gap, right? So that is one thing which can be combined. And lastly, you can do a cricothyroid approximation. So when you approximate cricothyroid cartilages, what is happening is you are actually pulling the vocal cords, right? And when pull it, it stretches and it prevents the aspiration, right? So cricothyroid approximation. So this is one of the patients which we actually did a cricothyroid approximation, and just passing the suture will actually cut through the cartilage. So we have used a mini clips, right? So that is one thing which can be done for these patients. For facial nerve palsies, you have to prevent exposure keratitis, right? So I think everybody knows about the management of facial nerve palsy, and the immediate management is to prevent exposure keratitis. You have to put the lacrimal gel in the night, and patient is asked to close the eye. In case he's not able to close the eye, you have to put tarsorrhaphy, or you can do a gold implant, right? So that is one thing which can be done for these patients. Generally, facial nerve palsy in these patients doesn't improve on its own. So he will have some permanent facial nerve palsy, and you can do other facial nerve reanimation surgeries later on. Depending on the I mean, if you have other cranial nerves also involvement, so probably you have to think what type of facial animation you need to do. Non-surgical rehabilitation can be done, and these involve basically swallowing maneuvers. And this will require patient to undergo FEAS or video fluoroscopic swallowing study, right? So these are the two studies which is important, and it will, because video fluoroscopic swallowing will actually give you a dynamic result of swallowing maneuver, right? And also you have to do a fiber optic evaluation. So these two things can be done, and you need to see what is the residue after swallowing. If the patient has residue in the valvula or into the larynx, there is aspiration present or not, there is a laryngeal penetration or not, right? So depending on these, we can actually ask the swallowing therapist to give him some maneuvers to improve the swallowing and prevent aspiration, right? So this is, I will not go into the details, but a few of the maneuvers which have been described to manage the lower cranial nerve palsy. So one of them is actually Mendelssohn maneuver, right? So this basically what the patient is doing, he is actually trying to, because there's a problem in laryngeal elevation. So when he swallows, and the larynx elevates, so he keeps the finger to maintain the laryngeal elevation during swallowing, right? So this is basically mechanically elevating the larynx during swallowing, right? And this can actually help in patient basically pushing the food into the cricopharynx. So because what happens when you elevate the larynx, the cricopharynx actually opens up, and there's a negative suction which is created, and the cricopharynx opens. So laryngeal elevation is very, very important, and this maneuver can help. And supraglottic swallowing, it is basically to prevent aspiration, right? So what patient does, he holds the bread during swallowing, and as soon as he swallows, he actually coughs voluntarily. So voluntarily cough is induced, so that if there's aspiration, it comes out, right? So that is supraglottic swallowing to prevent aspiration. Then there are, for 12th nerve palsy, you can actually do this maneuver to strengthen the tongue muscles, right? And this is basically the patient is asked to stick out the tongue, and he basically bites the tongue between the upper and lower alveolus, and then patient is asked to swallow. Okay? So that is Massaco's maneuver. Then there are compensatory strategies. You can actually modify the bolus. You can do dietary modification. You can do postural modification, and you can do sensory enhancement. So there are two methods. One is the chin tick, The patient swallows during with chin tick, and patient turns the head towards the stronger side, right, and then swallows, right. So these are the positional maneuvers which can be given to the patient, and then you can do more bolus modification, right. So bolus modification is also very important, and the speech therapist will be able to give different types of food and modify the bolus for improving the swallowing function. So I'm not going into details of this. And lastly, there is a vital stim therapy, right? So this is also coming in big way for helping these patients with swallowing disorders. So this is basically non-invasive electrical stimulation of the laryngeal muscles, and it basically retrains the muscles and improves the swallowing, right? So this is basically giving small amount of electric current to the neck muscles, right? So I think that's all from my side. Any questions if you have?
What's the good timing of rehabilitation, thinking of rehabilitation? Is it day one or patient is not responding?
So I think initially, I mean, I just skipped that part. Initially, patient has to be managed with Ryer's tube and percutaneous or endoscopic PEG, right? So because these patients are not in the stage that they can be taken to the OPD for these maneuvers. Sometimes they are sick patients. So initially, I would say that the patient has to be managed with Ryer's tube and PEG. And once the patient is mobile, probably then you can start with the
So we can avoid acute action or immediately. There might be whenever the nerve palsy start, the therapy can start there.
Sessions, same terminologies. Over the past many years, over a humble 20 odd patients of SBOs that we've handled in the past 2 years, these are just the last two, and they have contrasting outcomes with similar processes. So we thought we'll bring them out in open for good criticism as well. So let's start without wasting time. Most of our patients are referred from neurology or internal medicine. Some of them we do see in the outpatient as well as primary patients. This is a near 60-year-old male admitted with a progressive headache. This patient came to the ER, obviously was scanned in the ER as well, a primary stroke protocol MRI. Primary examination from neurology side was clear. Labs were normal except for a diabetic status, which was recent. His MRI brain stroke protocol, which is basically saying a non-contrast quick MRI, was reported to be normal. And post 2 or I believe 3 days of admission with a progressive headache, he was referred to us as well to rule out if there is any ENT cause for his pathology. Right now, we haven't called him anything. So this is a non-contrast MRI. Does it really ring any bells, sir? Would you want to make any assumption on this MRI at all?
Not really. I'll have to see more cards.
Correct. So the only thing, sir, anything else to add?
Patients, like he said, was it one-sided headache or was it a
Occipital headache.
occipital?
Yes.
No, I wouldn't be able to pick up on this.
Right. So for the most part, we couldn't pick up either. The only thing we sort of, penned to our neurology, to our radiology colleagues was that we thought that the nasopharyngeal thickness was rather odd and not really normal for the kind of MRIs.
Variegated also.
Yes. It's not normal. It's rather bulky and it's variegated as you rightly said. So on examination, on pretty much normal examination, we couldn't find anything. Ears are normal, no CSOM, no discharge, nothing. The nose is normal. Now, sir, my question, do you really go for a nasal endoscopy or a flexible endoscopy in these patients as a routine? You would?
Yes.
But I do. And in fact, another thing which I would say is somebody who's recently been diagnosed as a possibility of herpes zoster capalicus, which always remains in the back of my mind.
Right. Same, sir?
Yeah, we will go there.
That
When we did the same, we just saw that there was a generalized edema of the nasopharynx, very bulky looking nasopharynx, very bulky torus folds. Everything else was normal. But what alerted her was his CRP, remarkably high, right? And this was the first sign that we had that we need to probably image further. So, Ravi sir, I'll start with you. What would you really ask in this if we are to image further?
Contrast and finance and that is a Investigation of choice.
So this is his contrast MRI. Now you see now how a simple addition of a contrast, and as you rightly said that a temporal bone protocol telling the radiologist to scan the sinuses as well, apart from just the brain, would light up a lot of things. Look at the amount of contrast that his nasopharynx, the left side petrous apex is right now taking. And that alerts you that it is not a normal pathology and it is indeed going towards possibly SBO. And now if you also see, there is a central non-enhancing portion in the clivus. It also sort of alarms you to the fact that there could be possible necrosis, maybe a sequestrum, or maybe early abscess formation in the central clivus, right? So now as more investigations unfold, you have an early diagnosis happening. This is a contrast CT as well. Look at the central lesion in the contrast CT. This sort of, shows you a core that is basically non-enhancing. Sir, I'll start with you.
So we need to do a biopsy from the nasopharynx even if we are suspecting skull base osteomyelitis.
Correct.
And after biopsy, then we go further. If it comes as expected, no malignancy, we will treat it like skull base osteomyelitis starting on device. Culture,
The biopsy under local anesthesia, general anesthesia.
depends on the compliance of the patient, give him a choice.
Okay.
Can be done under local provided he is compliant.
If it's taking time, would you start IV antibiotics? No.
I can empirically start. If my dating is taking time for 3 days, then we can empirically start IV antibiotics, nothing wrong.
Right. Sir?
We'll also keep tuberculosis in mind in
Yes.
such cases because it's a bony clivus lesion with some degree of central necrosis. We'll corroborate with other parameters like your lymphocytes, your ESR, and maybe a chest imaging also.
Correct.
As sir said, possibly a skull base osteomyelitis or a tubercular osteomyelitis.
Right. So I think, as sir said, you would definitely want a biopsy, some kind of sampling to see what is happening. And maybe if there is the ability to take the patient under general anesthesia, that's a welcome step because you could both do a biopsy, you could go slightly deeper, as well as you can see if there is some kind of pus forming or sequestrum, you can possibly deal with all that at the same time.
But tissue should also be set for PCR, TB PCR. if we are
Right,
suspecting.
right, agreed, 100%. Right, so we sort of, took the same road here. We opened the sphenoid to see if there's anything there. There was nothing much there. So we thought we'll just explore the nasopharynx, standard approach towards the mid clivus or the lower clivus that we took. And the point here was to basically try to be as precise in the area of biopsying, both for culture, both for CBNAT, and not take a surface culture or a surface biopsy because that probably wouldn't lead you into what is happening. So I'll pass forward a little bit to see what we found. As we went a little deeper inside the mid clivus region, soft cancellous bone here, practically you can pick it out using a curette. We practically couldn't find any abnormal bone, grossly abnormal bone that we were suspecting. Now the scan was 5-day-old as compared to our date for procedure. And also we couldn't find any pus. So once we had taken our adequate amount of exposure, we thought it prudent to, we're doing this all under navigation control, just to be sure that we're not missing out to the area that we have seen on the CT. Now, the fact that we could not find anything that is grossly abnormal to look at, we took a lot of blind samples from this region. It was for, as you said, tissue culture. It was for CBNAT. It was for a normal biopsy as well, assuming that we could find something and direct our treatment towards it. This patient already was started on injection meropenem prior to this surgical exploration.
What bond are you using?
This is a precise max bond, standard coblation. So just to highlight as to what was the approximate depth of our choice of tissue, we wanted to be very sure that we are not missing on to that exact focus that we saw on his contrast CT and the contrast MRI to be sure that we are indeed dealing with that tissue. And we took it. And again, as Sir said already in the start of the session, that this was a very simple and specific procedure, did not have much morbidity. We could discharge this patient on day 3 on IV antibiotics, as probably we do. And this was what was initially, happening on the further post-operative course. Ravi sir, anything else from this, and how would you proceed?
Well, I think, I don't know, but why did you actually open, why did you undertake a surgical intervention? You should have actually given IV antibiotics, seen the response, and probably then decide. What was the need for surgical intervention?
Surgery was done for sampling because we have approved the other differentials, tuberculosis, lymphoma, carcinoma. They were also.
But you did not, you just coagulated everything.
No, sir. We coagulated everything. We went to the level of the pathology seen on CT, took curettes to scrape out the cancellous bone. Along with tissue here, we sent generous samples which we could not have obtained otherwise under a general sort of a biopsy settings. So this was for most part diagnostic. Had we got a sequestrum, we would have gone forward to remove it. Had we gone pus or an abscess, we would have basically cleared it.
The patient seems to be responding.
Patient seems to be responding.
So your CRP
Yes.
is down.
Yes.
Your pain has hopefully gone down.
Everything gone down, but sir, then the next question is, how would you interpret this methicillin-resistant coagulase negative staph? If you let us go into culture, commensal?
It's a comment.
Sir, even if you have gotten it right from the deep tissue, not really from the surface, it's from the area of the actual curettage of the cancellous bone.
But that can get expanded.
It has
Because you're
taken
dragging
it through the nose and
sampling,
dragged it
Fair
down.
enough, fair enough. So, I mean, just for that fact, we added linezolic, but we didn't stop his meropenem. We continued to give a gram-negative coverage, which we were giving him initially. And we just added linezolic since we had a culture and we couldn't ignore it. But we had now biopsy. We knew for sure we are not having a malignancy, right? All these patients also get an autoimmune workup, so we're not missing on to any GPA or such pathologies. So the next question is, how long would you give IV antibiotics to these patients on ambulatory basis?
So we start even for 2 weeks, reassess. Clinical response, maybe radiological, repeat MRI.
Right.
Every
2 weeks?
Not MRI every 2 weeks, clinical response every
Clinical
2 weeks. Maybe MRI after 4 to 6 weeks.
Right. So what do you expect in the MRI after 4 to 6 weeks? Does it really change?
Not a dramatic change on the second week or the third week. But definitely, if there is any increase or anything else that you're seeing in addition, I think I would go more by the pain relief and the response, the inflammatory markers coming down. These would give me a fairly good answer.
You may actually get a PET CT also. PET CT.
We didn't have a PET CT. We could have had maybe, but rightly said that the MR has to be interpreted with the symptoms as well of the patient and the clinical response. The patient looked fit. One of the things we take care into asking and taking into picture, apart from their pain scores, is are they gaining weight? What is their appetite? It really matters a lot. When patients come and tell us that their appetite is better, they're gaining weight on the same diet that they used to have, the pain is less, then obviously interpreting these MRs is far easier. Ideally, this MR at 4 weeks probably doesn't tell us much, apart from what we saw in the earlier MR as well. So we also did the same thing, but
we will not get an MRI until unless patient is improved. I mean, if the patient is improving, there is no need for a second MRI.
fair enough. You feel so, sir?
I think that is why that is what we follow in our. If the
I
patient is
kind of
improving,
agree.
I will not get a second MRI.
Because very often when you've done a procedure, there is such a lot of, there is edema, there is inflammation. So that can kind of confuse you further. So unless there is a very good reason, you won't want to.
So correct. And one reason possibly also for us to get scans for these patients is the continued surveillance as to we don't want to miss anything. If there's a new lesion somewhere else that is developing, possibly you want to have an heightened awareness as a, whatever route you may take for that management, whether it is medical or surgical, you probably won't want to sit on it and not look at it if, in most of these patients. This was a nice ending. We'll come to the other one. Again, a similar looking patient, a slightly leaner patient, known diabetic, poorly controlled, as sir said, much above 7, it's above 8. He also comes to the ER, progressive headache, but this time he's very sure in the fact that he tells us that it began as a left earache. But the left earache does not bother him too much now. What bothers him is the occipital pain. It's quite relentless. On examination, he has some tenderness of the left external canal, nothing specific. Has a very remarkably thick tympanic membrane with, if I must say, some inferior granulations, which you were quite skeptical to call them granulations at that time. He has had more than 9-10 days of IV antibiotics outside at his primary center, all kinds, including meropenem and ceftazidime and piptaz, all 3 days, three different antibiotics, and come to the CRP of 90. So are we at least going towards the diagnosis of SBO right now? Yes. Yes. So you have 2 scans in front of you, a non-contrast MRI and a technetium gallium scan. The non-contrast MRI, as always, again, does not tell you a lot. It shows you a practically normal-looking scan, normal-looking nasopharynx, right? Not too thick, quite clean. Whereas the bone scan shows you a diffuse uptake in the nose somewhere, right? That's all we know. Sir, next step from your side.
Next step, again, I'll do a laser endoscopy.
Yes.
Slightest suspicion, do a biopsy.
So biopsy from where?
Nasopharynx. If I feel there is some edema, or there is some, at least even for edema, we will do it.
Right. So I think I missed a slide here. There was a CT, non-contrast CT as well, which showed some mild sort of a sphenoid sinusitis. I'll just put that into perspective.
Yes, so there is sphenoid sinusitis. So treatment can be started. Again, same line. And consider treatment. And again, if you are going under GA for a biopsy, then open the sphenoid and do sampling.
Correct.
Because we have taken a sample from sphenoid, even if it is pus, is very simple.
But you would definitely consider that at this moment.
I will do that because it's a long haul of antibiotics to be given. Better to have a sample in the beginning. If you do it after a couple of weeks, it will come sterile.
So what about the ear? I mean, let's say you're not able to see any granulations there. What do you want to do something for the ear as well? As probably sir said, a laryngotomy.
You said that you were not convinced about the.
No, it's not.
So,
but a thick DM.
He
gave you
symptomatically much better.
The symptom began with the ear, he said. He had left earache.
Agreed, but he's symptomatically much better. You've given antibiotics, maybe that has, sorted that out. So the yield from the ear is going to be very poor.
Correct.
And photogenic symptoms can also be because of secondary reactive dysfunction.
Correct.
You would concentrate more on the.
Right. So we did what all sir said, we saw a lot of necrotic and sloughy mucosa in the left sphenoid, right? Not good looking at all.
There is no calcium in this patient, or there is a ear involved.
Not right now, sir. Not right now. So this is, I think, day 2 or 3 we'll be talking about. And we had taken him for a sinus exploration, sent all cultures, KOH samples, CBNAT samples as well. And this is what we had on day 2. Right? We had no growth. I mean, on day 3, whatever that was, no growth on tissue cultures. Of course, he was on antibiotics, a lot of inflammation with necrosis. And the KOH was full of broad aseptate hyphae, suggestive of mucorales, right? Immediately next day, he develops left-sided 10th and 12th nerve palsy. We initiate IV liposomal ampho-B. Of course, this was a MDT setting with the IV people as well. And on day 5, as his ampho-B was going on, his meropenem was going on, we also immediately did a small OPD sort of procedure to medialize the left vocal fold. He was not showing symptoms of aspiration yet, though we did not do a formal FEES to evaluate the same. Sir, inputs.
Yeah, this is fine. This is mucormycosis. Treatment has to be aggressive.
Yes.
And that will help to someone high dose. Monitoring the renal functions and the electrolytes. The electrolytes, magnesium is very important.
Right.
Sodium, potassium, magnesium is very important. And once you stabilize it, what is the end dose? You can you say 3 grams. There are other factors also which you take into account, but initially you can say 3 grams, and then you can be put it to oral isotretinoin or.
Correct.
Sir?
Regarding the year, something, what is the environment issue? And did you do a environment?
I don't think so. We did in pure tone audiometry. I think that had some mixed loss.
We can think whether it is there or not, but second drug itself can give a B type.
Yes, yes. So that's why.
With the caveat that
Yes.
second drug itself.
Yes, correct. So this is what actually transpired. So you would stop also at 3.5 grams?
Actually, coming to this, the literature was for this 3 to 4 grams was for amphotericin B, not for liposomal amphotericin. For liposomal amphotericin, that cumulative dose is not used, which was previously used
Correct.
for amphotericin B.
Correct.
For lipoamphotericin, this cumulative dose concept is not there. So there it is that you give between 5 to 10 milligrams per kilogram body weight, depending on if you're expecting an intracranial involvement, like in this case, you would go more towards 10 rather than rather than 5. And you need to have clinical response. So there should be significant pain relief.
And the response was good. Response was good till now, even in this sort of dose as well. We didn't give 10.
Yeah. So those were my points. Here is a case where 10 can be given. Of course, I also have the benefit of hindsight, which is not a good thing to have when you're in a panel like this.
So my question, how frequently do you use 10 milligram per kg liposomal ampho in your patients? How well is it
10
tolerated?
per kg or 10 grams total?
10 milligram per kg.
10 milligram per kg, we are a bit reluctant. If ID is admitting the patient, they will be keen to do that. But I'll agree with sir for dosages. Our dose schedule is 3.5 to 4 grams for sinonasal, around 7 for orbital, and around 10 or 10 plus for cranial.
This concept of cumulative is correct, is not there, but is the first stop.
Correct.
When you stop first,
Correct.
3 grams the patient reaches, 10 will be higher, 5 milligram per kg is a reasonable dose. Each first day you give a test dose of 50 mg, and then you give 5 milligram per, stop at 3, and again, the different parameters, CRP, ESR, whether MRI is required, clinical picture, then you can decide.
May I interject here?
Yes.
Again,
I
the
think
concept
there's
of
no
giving a test dose has gone out with
One out with them. Yes.
They do not advocate a test dose, and they say that you give
Full dose from day one.
full dose from day one. That is just a little add-on which I.
But protocol,
Most
even if
people
you
do
give the
that.
full dose, even if you give the full dose on first day, 50 milligram can be given first, and then the once there is no
All right,
reaction, the rest
Accept it.
started. Though there are hardly any side effects.
Accept it. Accept it. Anup, you
It's a
say
habit which is formed.
No, but unless you reconstitute it yourself, I make it a practice. I
Then we
ensure
don't do
that
that.
the first dose given is mixed in my presence, because we do not. Our nurses keep changing every. My hospital, the turnover is so high that most of them are untrained. They massacre the liposomal amphotericin, and like our ID specialist today said, unless you reconstituted it properly, you've used filtration. If you don't see that happening, you will have a reaction, which is the problem. So I ensure that I train the nurses. I'm doing this myself. First dose is in my presence.
We will call you to our hospital also.
say something.
I charge.
We have a equally in this case. We need to give
I asked a question to you. We have a diagnosis of mucor in this case. Would you give an antibiotic or not apart from that?
Mixed infections with fungus are fairly common,
Fairly common.
although I did not see that any
Nothing grew, sir.
reports or something, but maybe
The cultures were negative, sir.
one antibiotic I think you should give. Superadded infections are not.
So this is what happens. He comes back to the ER after 15 days, initially improving. Now he comes back with even a more severe headache, pain going to the neck, and a progressive reduced oral intake, overall sick appearance, and now has an additional 6 nerve palsy apart from the 10th and 12th that we already had. So immediately he scanned again, this time with a contrast to save time. And if you see, you can see almost contiguous disease from the left jugular fossa, petrous apex, the clivus, the occipital condyle, and almost involving the entire middle cranial base.
how is the diabetes down?
Diabetes is fairly controlled now. It was only uncontrolled when he came in.
Basically, he requires long-term amphotericin. Initially, you discharge patient after 10 days of anticonvulsant. Because it's a neural involvement, they have given a longer duration.
Yes, I mean,
Controls were not there when we started.
sir.
Cranial spread was not there when we started.
No.
Now it has gone to cavernous sinus. It is
Now
definitely
you can rethink of restarting liposomal with this.
Yes,
patient. It should be
Restarted.
Yes. So that's what we did. We restarted a liposomal ampho and upgrade the antibiotics as well, of course, with the IB team. But any surgical considerations now?
have the CSF for seeing the.
Was done, sir. CSF was clear. I forgot to put it here, but CSF was done by neurology teams in the IC.
Not right now. We are not gaining much surgically for this scenario. I think you should treat medically if disease is being brought under control, but prognosis is very guarded.
patient has the prognosis becomes guarded, then cavernous sinus gets or there is dural. Still is manageable. The liposomal will go on, but the day you see an abscess, you see cavernous involvement, and or you see treadmill, then prognosis is very.
Yes, agreed. So the point is, like I said initially when we heard your talk, was that sometimes in a contrast MRI, it is not very easy to differentiate sequestrum from a collection somewhere in the Peter's apex, somewhere in the deep skull base. And when you're fighting against time, when you have a patient that is progressively going down, with you giving the most aggressive IV treatment, both antifungals and antibiotics, you really press to the door as to what else you can do to safeguard this patient's life. So with due consent, he also had a second opinion from some other institutes, and he asked us the options of surgery. He was duly told that surgery is 80% diagnostic. If we can maybe find something else that we could not have found earlier on, if there's anything else, or if we can even reduce the amount of infection that he has. Anyways, I'll pass forward this. It was simple, a standard ITF-A approach. And so another question to sir, what kind of tissue do you really expect to take off when you take these patients sometimes for surgery? And when you do, let's say when you take them up for you're drilling some cortical bone, it's an extended cortical, the canal wall down. What kind of exact tissue are you looking to remove or to even send for sampling?
And the bone fragments.
Okay.
The bone dust.
Yes.
The mucosa, more so from the hypotympanoid. All unhealthy tissues that are encountered on the way. And if you find some glue or some pus, we do take swabs from them.
Right. So in this instance, our goal was basically addressing the PA, the Peter's apex, as well as the jugular fossa to see what kind of tissue we have. You have the tissue in front of you, thick florid granulations all over in the jugular fossa. So we thought if we clear them, maybe we have some help. I understand it's a sort of a lost cause, but just seeing it's not very common that we get this kind of tissue. A lot of flamboyant granulations, full of them, entire Peter's apex and the jugular foramen, the occipital condyle region. We couldn't drill it too much because of the fear of the cervico occipital instability. We had to restrict ourselves here. And then post that, we were also, apart from the KOH, we didn't have a biopsy that told us that, there are actual fungus inside tissue. Since we are going for this extent of procedure in these patients, it was also prudent to take more tissue, more generous tissue to be able to justify that this is indeed, if we are going to 20 or 25 days of IV liposomal amphotericin B and the upfront costs, we get something. Look at this bone. This is so typical of mucors, and this moth-eaten sort of a bone is very bad to look at. And obviously, you also know that this bone doesn't really accept drugs, no matter what you do. But this is also not, as Sir said, that it is not a lying sequestrum that you can simply pull off. It's all a dead bone. And in case you do so, sir, where do you stop? Well, the principle that one normally follows is you keep drilling till you start getting some form of bleeding. But here, that really doesn't hold true. Now, one thing that is, I'll say for both sides. One thing for surgery was you've got mucormycosis, which is, how permanent it can be. So it should be excised as far as possible. But we do not have any necrosis, which is obvious on the scans.
No, there is. The MRI shows you all black Peter's apex.
Okay,
And
that was black.
And the midlivus entirely, all in continuity.
So you can justify your surgery on that.
I mean, not even trying to justify surgery, but simply saying that where do we end?
You end it till you see no more necrosis. That's the.
See, in your you decide to operate, that's fine. Now the decision is taken. You divide however you can, except near the carotid.
Right.
Once you come near the carotid, obviously you save the patient. But near the carotid, you must stop.
So we stop at the carotid, right?
This is the white line.
Yes.
And a small rupture in carotid, but you will try to take out the fragments. This happened in arbicular mycosis cases. In the sphenoid, if you're working, it's not a normal sphenoid. The bone is very, very
correct.
This comes out. So injury to carotid is not perfect. Best to deprive.
Agreed. So we stopped at the carotid as well.
This case, did you make a decision on the 40% factor, the 7% is common, that may not be that easy of the point.
No, so it was not a decision. We spoke with the family as well. We had to take care of the length of anesthesia and the ICU stay. So we told them that initially, if it is part diagnostic, part therapeutic, there's higher chance that on the MRI we are seeing a lot of dead bone.
But you want to ask, why didn't you go central to periphery? You should have addressed the clivus part first because bulk of disease lies there.
Central to periphery, lateral to ICA, it's quite hard. And you cannot access the jugular foramen from the nose. At least we don't normally access jugular foramen from the nose. Our first area was to assess the jugular foramen, the Peter's apex, and then go towards the midclavus, if at all that remains a possibility. But the first approach was taken to remove any gross disease if we can. That is the whole point. Of course, as you saw, we cannot chase this till the end of it. Now, these are our cultures. The KOH this time came negative. Of course, he's on IV antifungals for quite some time. The CV NAT is negative. The cultures don't do nothing. And histopathology says necrotizing inflammation with vasculitis. Sir, how do you interpret this pathology?
Also look at granulomatosis with polyangiitis.
Yes.
In terms of patients, if there is a lot of vasculitis, we should also look at that.
So we sent all the autoimmune panel, it came out negative. And this time the CRP also wasn't much after the surgery with pollen. And so what I meant to ask was that histopathology as well in these patients has to be interpreted in line with the journey of the disease as well.
Don't get misguided by this. Histopathology, your diagnosis of liver is absolutely correct. Once you've seen that issue.
So we got a frantic call from the pathology department, sir, you have to send the autoimmune panel for this patient. We are finding vasculitis, We said, okay, this sort of, totally throws you off. But we could see that kind of tissue we have seen in surgery, the kind of bone that we have seen.
You've seen response to treatment also. So that also kind of helps. So how was patient doing after the surgery?
Sir, 6 days after surgery, the patient was doing far better. The pain was less, right? The counts were lesser. And of course, we had put him more or less recumbent. So his pain was less. His pain was mostly on neck movements, right?
After the surgery, continued with the antifungal or antibacterial?
Antifungals were continued. Antibacterials were continued as well. 2 antibacterials, 1 antifungal. And then in between, the neurosurgical team was also contemplating if they need to do a cervical fusion to reduce his pain, because his pain would essentially come on neck movements, would aggravate a lot, right? That was being discussed. Why it was not being done was because the fact that there was a lot of necrosis all around the lower skull base and the screws would not really hold. And that was why they had to, put it on hold, their original plan. Now, I think it was day 7 or 8, and his pain became relentless once again, throughout his stay. And this is just a CT that we had done post-surgery, post-primary surgery, just to see where we are. And now his pain was worsening, and the neurosurgery team was also contemplating if they can do a cervical fusion to ease his symptoms. And they were discussing if anything else can be done to reduce his central skull base infection. That's there, yes.
There's a lot of rare fractures. The clival lesion and the upper.
So, sir, what he asked, I'll ask you again. Now, would you contemplate also debriding his central skull base?
See, again, I will not go in. See, approach is a matter of surgical preference. If he is more comfortable going from central to lateral, it is fine. If somebody is more comfortable, more versed with the lateral skull base approach and is confident he can handle the neurovascular structures better, it's fine. But no second, not
And moreover, see, again, playing devil's advocate, when you were moving tissue, they were vascularized. There was no avascular.
no, it is.
So there was a lot of dead bone.
Dead bone, yes, but after, I'm talking about the soft tissue component, was vascular. And what else would you like to remove actually? How much? There is a finite amount. You can't do more. You can't do more than it is. You can't become God.
There is so much of obvious necrosis in this histopathology should not necrosis problem.
No, histopathology has to be interpreted with the clinical context. Clinical context is in front of you. That you are seeing the imaging, you are seeing.
Other necrose bone was drilled away.
Get a slide review from another.
It was sucked away.
That too as well.
The necrotic tissue was sucked away. It was the tissue that he took was more vascularized. So
Did you start a steroid?
No, sir. We didn't start a steroid because we had sent the autoimmune panel. It came out negative. No way on earth that we were willing to start steroids in these patients. Then antibiotics already very poor immunity, diabetics, no steroids absolutely. But yes, I mean, it was not to our pleasure. We don't normally do these procedures for these patients. They are reserved for mostly tumor patients. But this was again one of the only incidences in all our existing patients where we were found ourselves pressed to the wall. All antibiotics, in fact, to be very honest with you, all our mucor patients, it has never been so that despite our IV liposomal ampho B, we have had to switch to it again. Most of them have responded well to either posaconazole or isavuconazole, and they've been okay. Or even if we've had that occasional mortality, it has been quite lengthy, been after many weeks or months with some MI or CVA and all these things, and not because of the disease per se. So we again took our chances, maybe wrong, I can accept that. But we had no other option apart from the drugs that we were giving. We took on to a central clivectomy just to see if there's more tissue that can be removed that reduces his burden of disease, or that at least makes him fit for a cervical fusion so that his pain can be relieved. And again, sent samples. They came as nothing. This was a pretty much standard procedure. And once this was done, he was observed in the ICU for a day. And then he was brought back to the ward after doing a peg insertion. Still not tracheostomized though, right? And then once this has happened, his dysphagia was pretty much absolute. That's why we had to put a peg. The fever again was, and we had rising CRP counts, and once again shifted to ICU. And this is what we found in the end, that this was a fulminant sort of a lung infection. As per a radiology team, though we could not get an opportunity to, take cultures from this. They thought this looked fungal to them as well because of certain appearances. I'm not very aware of what they were looking for, but they felt so. This looks in sort of fungal, apart from some amounts of aspiration that you see in the bases.
Right. The
It is same, just shows non-specific inflammation and nothing else. And the second or third day of ICU, eventually mortality happened, and from a septic shock. So, I just thought bring out these two patients out in the open because two very contrasting outcomes in both the patients, despite similar sort of processes. What changes outcomes? Maybe fungal, I'm not sure. The fact that it was mucor maybe was already.
the prognosis is bad. Whenever you have aseptic IP, C on first QH is the best diagnosis.
Yes.
Test may do any number of tests, but that and many of us should rush to the lab, see the slide outside.
The diabetes patients, the diabetes was under control.
Yes, sir. It was not controlled when he came to us for the first time, but by that time he was already getting insulin injections. He was getting IV antibiotics for 9-10 days outside in some other center when he came to us with the progressive headache and whatever they had seen on the imaging.
And no other comorbid.
No, not really.
When the first biopsy was taken from sphenoid, it was I believe in the sphenoid sign or it was from the.
So it was the sphenoid. It was the sphenoid mucosa. We stripped off the entire mucosa of sphenoid. We sent that en bulk as a sample. We don't believe in sending small punch biopsies.
The pathology actually showed invasion of the sphenoid mucosa with the fungal.
No, sir, it didn't. Histology just showed.
Just a fungal form.
I'll not believe, sir. I mean, a fungal ball with this much of destruction.
Was the next biopsy from the surgery in the latter part of the temporal bone, when we give patient or when that stent is, there was no fungal element.
Sir, pardon me on this one, but I'll ask all of your opinion only on this. I believe that there's nothing called a mucor fungal ball. If I am, at least in my thinking, my mind, there's nothing called a mucor fungal ball. Fungal balls are aspergillus by definition. If there is, we have had, I think, 2 or 3 instances where we had, we thought of them as fungal balls and they've grown mucor.
Well, it's a spectrum of it. Depends on the immunity of the patient. If the patient is totally competent, competent, so interestingly, he might be having a fungal ball.
It's a pain. He was having severe pain, raised counts.
That could be bacterial infection also. It could be bacterial skull base osteomyelitis.
So interestingly, I looked at it during COVID time. There is no population-based survey on how many harbor normal mucor illnesses in Indian population. So it's not. I didn't find any literature on this. I don't know whether it exists.
It's a spectrum. On one end, you have a totally immunocompetent person who can have fungal ball.
It would be good to do a population-based survey.
On the other hand, we have acute invasive fungal.
But sir, you also agree that even in acute invasive mucormycosis, it is not always that you see fungal invasion in the tissue. Sometimes you just have necrotic inflammation.
But tell me something.
See, mucor is causing endarterectus obliterans.
Yes.
It is affecting the vessels and distal tissues are getting
Why
damaged.
it is causing? Because it is actually growing inside the tissue. That is not why it is causing endarteritis, obliterative endarteritis, right?
But
It is
have
not-
we ever seen asymptomatic mucor?
I've not seen. I've not seen an
Very
asymptomatic.
unlikely.
We've not
No, we
encountered
I've
it.
not seen.
And the fact that there was there is invasiveness, we kind of will treat it as an invasive.
No, I'm just saying that I have not yet seen any mucor ball which is
fiction. It is present everywhere in the environment. It doesn't cause problem in a competent person. Isn't it? It will cause problem when only if actually the patient has low immunity, immunocompromised state, and it creates the disease.
So, but the different species of mucor are commensals also. It only causes immune. That statement is correct. But this is unmistakably invasive.
because the biopsy would tell you that there is necrotic inflammation. There is mucor that grows a lot in the KOH. This patient has pain, elevated counts, progressive pain, is a diabetic. So I think with all our mucor patients, whatever humble amount we have done, we couldn't always find the actual tissue invasion on histopathology. If we would, yes, it's a gold standard. I agree. That is true on fungal stains, past stains, but it is not always so. So in case we have heightened suspicion and we find so, I think we have to put that into perspective.
Then PCR for mucor also works.
Never done that.
You will send a tissue, the tissue for PCR.
On the tissue.
Yes. Mucor PCR, a good lab gives positive. Several cases during COVID we had where even the QH did not give a aseptic type, but PCR.
But sir, in the same light, does a PCR give you evidence of invasion or not? Would you take it as
It
invasion?
doesn't talk of invasion or non-invasion. It is only tell you.
You can add on to your KOH.
Yes.
Add on to a KOH, probably. Right? Just these 2 interesting cases I thought I'll bring out and take some criticism for them.
Very nice.
Thank you so much. I think it's a pleasure to have you all here. Thank you. Just before you leave, 2 minutes for one picture. That's all.